Hey, you there, Warlix? Well, you're in there. Good morning, Harshad. Welcome.
What time is the evening?
How you doing, young? We start in 30 minutes, okay?
I know. 30 minutes.
30 minutes.
A little delay.
No, this is the right time.
Right time? Yeah.
Yeah.
Okay.
Yeah, it gets kind of strange. Yeah, the time is confusing sometimes.
Yeah.
Especially in South America, the time changes a lot.
Because this time in Kairos afternoon.
Okay.
Cairo.
Warlix, are you there?
Yes.
How you doing?
Oh, yeah, I'm good.
You're very muted.
Huh?
You should be excited.
Yeah.
Yes.
I
That's
don't
correct.
hear the excitement, Warlix.
Yeah. Exciting.
Well, listen, I want to talk to you because I think we may have some good news, okay? Maybe after, maybe later today or whatever, okay? Okay, Warlix?
Okay.
Okay, whatever.
Sure.
She must be busy, you must be busy.
Thanks.
Don't worry, just be yourself, Warlix, like you always are.
Okay.
Okay, we start in about a half hour. Okay, we're getting ready to roll. Sam is arriving. I hear the trumpets. Does anybody else hear the trumpets? Well, maybe that's my neighbor trying out his new horn. Trying to get someone in here. I think it's a Chinese translator. Sammy, what are you doing? I'm trying to get you in. Dr. Shah, okay, great.
John,
Hey, Dr. Shah, how you doing?
good.
What you been doing? Sam, are you trying to get, Sam, can you hear me? Sam, can you hear me? Looks like, I don't know if you're trying to get in or not. Or you're trying to get in.
Yes, I
there
am
you are.
here,
Oh, okay.
waiting for you to be panelist.
Okay. Yeah, I had a hard time getting you in. Hey, Sam.
I am here,
Okay,
button
listen.
attendees.
Yeah, Sam, Warlick's is a little nervous. You need to give her a pep talk. You know what a pep talk is?
Mhm.
Warlick, you met Sam, right?
What?
I was
I
just want to
didn't
know
get you.
if you have met Warlick's. Are you there,
Yes.
Warlick? Are you there, Warlick's? Maybe not. Okay. It looks like you're on two computers, Sam. Are you on two computers? Okay, there you go. Okay. I guess you fell out.
Okay, John, please upgrade the second one.
Got your camera set on the time, Sam. Sam, you need to put your camera on. I can't see your face. Okay, there you go. Okay, you're sideways, Sam.
Please
Okay.
upgrade the second one.
The camera is sideways. What is, okay, is a smartphone? I guess you have to turn it, right? Or just the screen on the smartphone. Right, Sam? Good morning, Yasser. How you doing? I don't know. I'm Dr. Bennett. We start, you're muted there. Sam, I need to see your camera.
Hello, John. How are you?
Good. How are you? Welcome.
Thank you. Thank you very much.
Where are you from, sir?
From Yemen.
Oh, very good. So you came to the conference, was it a couple of days ago, yesterday? Was it?
Yes, yes. I attended the yesterday conference with the Romanian neurosurgeon.
Yeah, that's good.
Yes.
He's quite an ambitious boy.
Yes, thank you. Thank you.
He's just a medical student, right?
No, I'm a neurosurgeon.
Yeah, but the person that organized the conference.
Yes.
Yeah, Ahmad, yeah. Okay,
Yes.
we start in 23 minutes.
Okay.
There's Sam. Okay, you got it. Hey, there's Warlix. You're
No,
muted,
this,
Warlix. You're muted.
Okay.
You're muted.
Hi, Dr. Sam. It's very precious to start the conference. Yeah. Thank you for giving me a chance.
Sam, Warlix is nervous.
No. Don't listen to John.
No, I said, don't, Warlix, there's only 10,000 people watching. Don't worry about that.
Don't listen to
Right, Sam?
Yes.
John, I will be
Looks-
nervous because of
looks
you.
good. She looks so good.
Yeah.
As usual.
As usual.
And she
How are you
will be
doing, Dr. Sam?
perfect. I'm fine. What about you?
Okay. I'm fine, pretty good. Yes, thank you. It's been an honor to have a talk in your
Well, I think,
conference.
Warlix, I think a lot of people want to see what you're doing. I mean, you're doing a lot of exciting stuff, it looks like. And I like
Yeah.
today's a good one. Yeah, it's that stuff's exciting because we don't normally see that in neurosurgery anyways. Maybe the other specialties they do it, but you just don't see it in neurosurgery. The creativity and the work, which is nice. It's nice to see.
Okay, John, 2 minutes to start.
Oh, really? I have 9:40. I have, are you sure, Sam?
Yes, Wolex will start by giving her
Oh,
lecture
okay,
for 20
okay,
minutes.
okay. We'll start in a couple of minutes, you say?
Yes.
Okay, just let me know when. That's right.
Okay,
It's 4:30. Yeah, it's 9:30. Yeah, it's 4. I understand. Yeah.
Yes,
Okay.
I will open the session, then you will introduce our great painter, Wolex.
Okay. Yeah. Okay. Well, let me start with you, Sam, first. Okay, I'll introduce you, and then you introduce Warlix. Is that okay?
Okay.
Okay. Let me. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett hosting a very special webcast of the EWNC Neurosurgical TV collaboration. And we have a really good lineup today. And I'm going to let Sam. Oops, we have a little background noise here. Okay, I'm going to introduce Sam, who's going to do the proper neurosurgical introduction. Welcome, Sam.
Thank you, John. Dear friends, welcome all to our seventh session from our series, Neurosurgical Approaches. Today, we will talk about frontal approaches from different views and from different concepts. So we will start with Rolex. Rolex, please start sharing your screen.
Hi, everyone. It's been so I unmute. You hear me?
Yes.
Okay. So hi, everyone. So my name is Dr. Walalak. So today it's been an honor for me to present in this topic. So this is what I'm going to talk about today. This is my art in neurosurgery. I am neurosurgeon myself, actually neurovascular interventionist, but I'm also the medical illustrations and graphic designers, in which I work for the Neurosurgical TV as well. So who I am, of course, that I finished the general medical students being internships, and I finished the neurosurgical residence in Thailand. And then I furthered my study as neurovascular surgeons and interventions fellowship programs in Japan and in Thailand. So right now my subspecialty is I'm working as the neurovascular and neurointerventionist at Chiang Mai Neurological Hospital, Thailand. But as also why I study, I also like to draw and illustrate about the anatomies and neuroanatomy. So it's kind of the learning process for me that in which it's helped me to studies too. In which I start to take it serious since 2019, in which at the same time when the have a COVID comes until present. So this is the QR code for if you are interested in my work. So today I'm going to talk about what is how do I start my work? So why do I start to draw? Why are you training or in the medical students? So as you see that in the textbook, there's a lot of text, but maybe if you start to read something, maybe if you see the picture, maybe it can help you to concise the main topic, and it can help you to know what is the main focus. This is my favorite textbook that from the Neurosurgery of Cerebral Aneurysms by illustrated by Dr. Sentaro Ito. He's neurosurgeon from Japan. It's very beautiful. So let me brief to you about the history of medical illustrations. It has been found before the 15,000 BC, in which at the very early it's only the pictograms. For the first anatomical illustrations, it's only an elephant with the heart shapes on that. And after that, with the ancient Egyptians, Romans, and Renaissance, and until now. Even the father of neurosurgeons, Dr. Harvey Cushing, he also the illustrators himself too. Nowadays, there have a lot of illustrators and wonderful artists all around the world that creates. This is the fields of the artists or illustrators that I follow. So Aristotle used to say in the 4th century BC that one might begin philosophy but would end with medicines, or start with medicines and find oneself in philosophy. But for me, maybe I find oneself in medicines but would end with art, or start with art and find myself in medicine. But I would not say that I would end with art, but for me, medicine and art can be collaborated. The use of art in medical illustrations can help in the learning process, traditional arts and combined with technologies, help for teachings and discussing process, and help to solve the communication dilemmas. It can make some things that it's complicated to something it's simple and bring them to life. This is just a few of the books that I used to illustrate. I did not update it until last year. The first book that I illustrate is for when I was in the neurosurgical residence, before I almost like finished the training. So for the first book that I illustrate is Common Neurosurgical Conditions and Pitfall Found in General Practice. And the first book that I illustrate is the black and white illustrations. I do not only illustrate for only the neurosurgical fields. I also illustrate for other surgical fields, such as vascular surgeons, plastic surgeons, or even general surgeons or oncologists too. And I also like illustrate for Thai massage acupuncture points. And I also collaborate my works with my professor in Japan. And I also collaborate with the handbook in neurotrauma in India. This is an example of the illustrations. For the beginning, maybe it's just only a cartoon and make things like, look simple and easy to understand. It's easy for the for the medical students or maybe the first or second years of the neurosurgical trainings to students to understand. This is the vascular injury textbook in which I illustrate almost the entire of the books with the vascular surgeons. So that's why I found that, okay, maybe I will further my study to be the neurovascular surgeons. So I not only like illustrate, so I think that my type of illustrations have unique. I do not have the lines at the end, but I also do the graphic designs too. So what interesting me in doing illustration is you not only draw what they ask you, but the writers or the professor have to tell you what is the idea of the book or the article that they're going to tell. So it's kind of not only draw, but you just just know some other ideas or other details too. I also, besides the textbook, I also illustrate for many of the medical articles in Thailand or in other countries worldwide. So I really exciting to work with every writers, because it's kind of, for an article idea for me is kind of something that is new created. So before we going to draw the draft or illustrations for each of the articles, so we have the brief talk with the writer first, and then maybe sometime I have to concise or tries to make the ideas into the pictures and create something new. So it's not only as you see that there's not only the neurosurgical fields that I illustrate for. So maybe sometime for orthopedics, plastic surgeon or vascular surgeons as well. This is, I will give you an example of some of the paper that I used to illustrate. This is that I'm proud of. I illustrate for the progress in neurosurgery contributes to women neurosurgeons in Asian and Australasians. So I contribute the information about Thailand and I write some of the paragraphs. And I just contribute the illustrations for them. This one is called Surgical Mind. This one is called Window to Neurosurgery. So for the meaning of each picture is kind of it's have me actually at the background. But for me, just for this article is that tries to empower the women neurosurgeons. What we do in the surgical field innovation is not different compared to the men surgeons. Actually, for me, just maybe we just too busy, but in our mind we just thinking about what is the best way to do for the surgeons. And this one is called Window to Neurosurgery. For me, in this meaning is when we think about we have to operate on some things to the patients, we have to think about the best way or which window is the best approach to the patients. This is work that I corroborate my works to the orthopedic surgeons, in which he tries to demonstrate the endoscopic assist odontoid screw insertions. I also do some of the surface anatomies. This one I work with the anesthesiologist textbook, in which they try to explain or write the details about how to do the anatomy in the obesity patients. This one, this paper just published. I work with the neurointervention, the Dr. Anjali in Thailand. So I create her the cavernous sinus anatomy, in which I start from like talking about the idea, what she wants, and then I just like create the new illustrations for her. And then it just kind of like, the original draft of the illustrations, and then I just like send her the draft, and then she's gonna look at that again. So the easy for me, and I think that the way that I work with the doctor is because I am also neurovascular surgeon too. So I kind of like, every time when I work with some doctor, I would feel that I always learn something new, and maybe of course there's some like minimal details and things that I can like can fix or can know in details by times. This one sometimes because I like to draw the post-operative operations that I do, so that I just can remind of myself that okay, this is like relaxing time by post-operative picture. This one I do illustration for the anatomy of the peripheral nerve, anterior rhinoscopy. So it's not, sometimes maybe it's not only focused about surgical like idea, but you can tell me like, what type of illustration that you want. Maybe you can want to see the patient's expressions as well. This one is for like demonstrate how to use the equipment. This one is I try to depict how to make the operative note just like more easy to understand and interesting by adding the details and adding more like, beautiful illustrations from that. So if you like interested in my work, so most of the time I just like, I found it more easy to post in the Instagram, so you can like go through, see, some other of my arts there. So I also the editorial board for the Asian Journal of Arts and Culture. And I also work for the Neurosurgical TV. And I also illustrate, as I told you before, that not only neurosurgery that I illustrate for. So I used to illustrate for the Royal College of Thailand Surgeons for the basic science projects for their textbook, and do arts exhibitions. This is some of my art that I use to work besides the neurosurgery stuff. So if there's a medical student or neurosurgical resident or a fellow, here. So where do I start? I have to tell you first that I'm not born with talents or artists. I'm not artist. I never learned art. I never go to the art school. So I just like, begin from the very basic stuff, from the paper sketch. Like when you go to the anatomy class, when you in the medical student, so just make a short note. But for the better way for me is to like, draw a picture, so it can help me to learn it much better. And then when I go train at a neurosurgical residence, I start to draw an operative note. But for me, as that English is not my first language, so most of the time I will like draft and draw the picture on the operative notes, and then I just fill the information after that. And then after that, when I just got my first like digital iPad, so I just started to do the digital illustrations. So things take time. I did not like start begin as make a beautiful art from the beginning. Everything is like the surgical skill. It takes time, so just be patient. And you should, and I got questions every time that how can I do it, because maybe some of you do not know how to draw, but for me, you just like grab the pencil and just try to draw some lines. And believe me, if you do it every day 365, you will see the amazing results after that you like do it every day. So this is the paper sketch in which I do when I was in the medical students. So when I go to the anatomy class, so I just drawing, and then highlight and read through my note a lot. So it's not only the pen or pencils that I do. Maybe sometimes if I have more time, so I just color it. So it's make it more like, relaxed for me. And after that, when I was in the neurosurgical residence, so of course I told you that I start to draw my operative notes. So most of the time so it's helped me because sometimes that if you just only observe, maybe the incisions or the idea how to make an incisions is different. So you just like, maybe only the sentence, or maybe you will forget in the future, but to make a picture, so it's more clear to understand. So this some of the my operative note when I was a neurosurgical resident. Most of the time it will be aneurysm case in which it's my it's interest me. So most of the time I like to draw the human figures too, because also, I mean, for me, the surgery, every step is important. So I do not only draw the finding, I will draw things that like what it should be the proper scalp incisions, how to decide, like, which way you're gonna put the muscles to, always the best way to do the first burr hole or something like that, and especially the dura incisions. Yeah, this is maybe if you close the scalp, maybe other people will not know what you do to the patients. So for me, I like to draw the pictures to show. So maybe other person, if they read my operative note, they will like have an idea what I'm doing in the field. This is the spinal case. So I just like, pay attention to the detail, even the positions of the patients, what it should be, the incisions, what is a surgical finding. This is a clipping of the aneurysm. So as you see that, you just do not need a fancy, like, instrument, just only your pen when you go and work every day, and the paper, that's all. And this is from when I go to join the cadaveric workshop. So of course, it's the best way when you just only see if you just only standing and watch the professor, like, demonstrate in the TV. Maybe another day, if you do not take a picture, maybe you forget. So for me, I like to, like, just make a quick draft and what is the important, like, steps. Or sometimes I just tries to, my teacher used to told us to try to draw what is the possibility of the operative view that we should see before we go in the operations, and then we draw it in the post-operative. So as you see that sometimes I just draw from the beginnings and until like we finish the operations. Okay, so then I move to the digital operative note. So it's more easy for me to understand. And for the residents too, if you have to present the case to the other surgical fields, such as general surgeons, vascular surgeon, maybe they do not understand if you only try to explain. So it must be better if you represent it by the teacher, so they will have an idea what you do. So sometimes I just, if I have time, so I just like, do the color it's too, and make it more like that to me. So it can help you to like remember what is the, can help you to remember what is the operations. This is the P2 dissecting aneurysm. Yeah, so as you see that, I kind of like, draw every time. And when you continue doing that, every anatomy will be the same, as it can help you to remember the anatomy more exactly too. So as you see that the drawing, it's help you like when you just see the images and you have plans to go to do the complicated case. maybe you can like, have a surgical planning in advance by just like, try to get what is the relative with the tumor and the nerve or the vascular that important. And then when you go and see, and if everything was right, okay, maybe you just like, have a complete understanding of anatomy. Or if something's wrong, you just like, go out after you finish the case. So you just like try to draw it again. And then you compare the pre-operative you're drawing and post-operative. And then when you continue doing that, so you will like, more precise in the surgical anatomy.
2 minutes, Walex.
So why do I prefer drawing operational? Because it's farther, clearer, and it can help. And how do I find the drawing is useful? As I told you that used for do the pre and post-operative notes, help for surgical planning, help memorizing. It's relaxed and fun. So the program that I use now is the Procreate program, in which it's on an iPad, but the point is we have to buy it, but only for one time. And it's you can draw and draft the note. So this is one of the things that illustrations can help. So you just do the pre-operative note before you go into the crimping. And then you just, once that you see, it's kind of like, an answer, and you just go out and you just draw the picture, what you see, and you compare. For me, I just continue doing that while I'm training. So, I mean, for now, I just can't picture like, in my head that what it should be like. So, or maybe sometime if you do not like, don't know how to start. So for me, maybe if I can have time and take the picture from the microscope and I just track back, I just draw it from the picture, from the post-operative picture, and it's just like, keep practicing and drawing after that. This is also an operative note in which I just like, I have more time, so I just draw myself too. But actually, this is the other thing that can help me, like when I train the fellowship in vascular. So for the, maybe if you read, maybe you cannot know detail, but for me, so I just like, drew some of the animations to do. This one is suction decompressions technique. So drawing, it's like the surgical skill. So if you compare like before like 2018, 2020, it's like different. So it's improved by time. So this is the work that I used to collaborate my work with Dr. Ibe. And sometimes for the comic book or the magazines that I can collaborate the neurosurgery illustrations too. So I try to make like, neurosurgical operative note to make it more like, interesting, fun. So this is the project that I want to do, but yeah, it's I still keep doing that. It's the paper that I working with Professor Juha. This one is the penetrating injury that I work with another neurosurgeons in Thailand. The trauma case, burhole case, bypass case. Yes, I do bypass, and maybe on the picture you cannot know because it's all red in there. So you just draw it, and it's like, mark about that. So almost the end. So I'm not only drawing, but I used to give an art class to the neurosurgery residents to draw a very simple one, just only 1 or 2 hours. So it's make them like relax and have more comfortable with the drawing. That is not, it means that everyone can do it. I try to say that you do not have to be the professional artist. You do not have to go to art school because you are still a surgeon that's learning. So you just draw in your style. So as you see that, that note is not that bad. Everyone can do it. So yes, this cartoon aneurysm is like monster for me, but right now I can like do intervention. So it's along with the crimping, so it's more easier for me. So thank you very much. This is my information if you're interested in my work. Thank you.
Thank you, Alex, for this excellent presentation. And now we will shift to next speaker, our eminent mentor, Professor Lawton. Please start sharing your screen. Professor Lawton will talk to us today about his experience, which has built from using frontal approaches in management of his patient. We will enjoy Paul today. Thank you, sir, for accepting our invitation.
Okay, well, thank you for inviting me. Can you see my title slide here?
Yes.
Okay, great. Well, once again, great to be included in this conference, and thank you for asking me to contribute. So in the theme of the frontal approaches, what I thought I would do is talk about frontal approaches to brainstem cavernous malformations, something I've been working on quite a bit lately with the new book project. And here's just some numbers to preface this. These are my total cavernous malformations, over 1,000, pushing into the next 1,000. And then the brainstem numbers are over 350 now. So I've used this experience just to gather some of my thoughts. You might have noticed in the JNS, Journal of Neurosurgery, there's a collection that's been running on the different articles for this project called 7 Cavernomas. And the effort here has been to develop a taxonomy so that we can have a consistent and unified understanding of these lesions, not only in the brainstem, but in deep structures and throughout the brain. Secondly, to advance tissue-sparing surgical approaches through subarachnoid spaces to deal with these lesions. Thirdly, to improve our diagnostic acumen, our decision-making, and our technique and outcomes. And finally, to leave our students and residents with meaningful heuristics so they can work their way through these challenging management decisions and these tough lesions surgically. So I'm just briefly going to remind everybody of the taxonomy because it's sort of the key piece of all this. And this is the way I think about brainstem cavernous malformations. They're broken down into types and subtypes. The types are the different portions of the brainstem, midbrain, pons, and medulla. And the subtypes relate to the surface that the lesion comes to. And you can see for each of the types, there are either 5 or 6 subtypes. And I'll just walk you through these. For the midbrain, these are anterior and anterolateral views. And you can see for the midbrain, we've got the interpeduncular and the peduncular subtypes. For the pons, we've got the basilar, peritrigeminal, and middle peduncular subtypes. And for the medulla, we've got the pyramidal, olivary, and cuneate. You can see those in the pure AP and then the anterolateral views. As we come around to the backside, you can see the other subtypes. So for midbrain, we've got quadrigeminal and tegmental. For pontine, we have the rhomboid, which is the floor of the fourth ventricle, and we have the inferior peduncular, which is where the inferior cerebellar peduncle wraps around into the pons. And then as we go below stria medullaris and into the medulla, you can see the lower half of the floor of the fourth ventricle, the trigonal. As we get outside the ventricle, we have the gracile and the cuneate. So these are the 16 subtypes. And if you can categorize a malformation into one of these, the beauty of it is you can really guide your decision-making and management. These are just ways of looking at those same subtypes cross-sectionally. So it's not just the surface, but also the regions. And you can see in these sliced views how the interpeduncular and peduncular lesions relate to the interpeduncular fossa or the cerebral peduncle. The tegmental lesions relate to the tegmentum on the posterolateral surface. Quadrigeminal lesions are in the tectal plate, and the periaqueductal ones are here around the funnel of the aqueduct at the top. In the pons, same idea. The basilar ones are located in the midline. Peritrigeminal is between the line of the sixth nerve or the transolivary line and the trigeminal root entry zone. Middle cerebellar peduncle is here out by the lateral to the fifth nerve and out to the petrosal fissure. We've got the rhomboidal and inferior peduncular ones here in purple and green. And finally, same idea with the medulla. We've got our pyramidal, olivary, cuneate, gracile, and trigonal ones all laid out for you here. So this is an approach, or a conference about approaches. So I'm just going to spend the rest of my time showing you examples of these frontal approaches to lesions that are in these various subtypes. And not all of them will be approached from the front. A lot of these are approached from the side or from the back. So I've excluded those, but I wanted to just cover the ones from the front to fit with the theme of the course. So I'll start with the interpeduncular. And here you have a nice illustration from Peter Lawrence showing the orbitozygomatic approach and the transsylvian interpeduncular approach to the interpeduncular midbrain cavernous malformation. So this is the critical anatomy here. You can see it's exactly like you would use to approach a basilar apex aneurysm. So you're going to split the sylvian fissure, open up this corridor, get pretemporal, walk along the PCA medial to the third nerve, down to the basilar apex, and then work through the thalamoperforators here in the back and get to the interpeduncular fossa. The key working triangle is the carotid oculomotor triangle here, shown in the upper right. And the safe entry zone that you use for this is the interpeduncular safe entry zone. So let's go to the videos here. So this is a case of one of these midbrain lesions, and I won't get into all the clinical details. I'll just show you the MR imaging here. You can see very nicely how this sits exactly in the midline, right between the cerebral peduncles in that interpeduncular fossa. And so for this, we're going to go transsylvian, just straight down the middle, and it's really not so unlike a basilar apex aneurysm that's pointing posteriorly. So we do the orbitozygomatic approach, some illustrations shown here. These are the key steps, and I'll just jump right into the video. So I did this from the left side because he had left-sided ocular motor symptoms. So I didn't want to produce a new third nerve palsy on the other side. So you can see the dissection here working down along the carotid artery and PCA. This is PCOM. So you follow PCOM back. I'm going to show you here how the PCOM can be divided. And by dividing the PCOM, you open up this working space. You release the PCOM, which jumps to the right, and you can move the shoulder of the P1, P2 junction to the left. And now we widen that space in the interpeduncular fossa. You'll see right there, these thalamoperforates right there that can be mobilized away. And as we get into the interpeduncular fossa, you see how this malformation just sits right there in the center. It's sort of exophytic into the space of the interpeduncular fossa, and we get right in. So this approach, it's quite deep, as you can see, and lots of critical things around, including those thalamoperforates and the third nerve and so forth. The mammillary bodies you can see nicely up here, but you've got plenty of room to see what you need to see. The resection technique is just an intracapsular debulking. So you use the capsule to protect the adjacent midbrain structures. You work inside the lesion itself. You're basically coring it out. And then as the lesion is reduced to just its outer shell, you can work those portions of the capsule into the center. So this is just more of the resection. And I think I'll get you to the end here where we've cleaned it out. You begin to see here this clean gliotic margin within the cavity there, indicating that everything's gone. So this is just our surgical tour at the end. You can see the P1 here. PCOM is right here. P2 is over here. Here's our third nerve. You see the basilar apex right there, the contralateral third nerve and P1. Beautiful overview of that anatomy. And the tentorium is intact. There is no need for anything fancy like a clinoidectomy or a transcavernous dissection. It's all just working through that carotid ocular motor space. So this is really a nice example of this exposure and the treatment for this lesion. So I'll just show you another example, similar lesion. Let's just look at the anatomy. But what's different about this one is that it's a little eccentric. So when you look at this MR, you can see that it's in the interpeduncular fossa, and that's where we need to go. But it's over to the right side. And to come in from the right side and try and get around the peduncle and to the back portion of that lesion, would be very difficult. This was a patient who had had 2 prior surgeries, one from the top, it was a transcallosal transchoroidal fissure approach, and the other from the right sylvian fissure. And you can see that after 2 operations, there was still residual. So the approach that I selected here was a contralateral transsylvian interpeduncular approach. So I'm going to go from the left, and you can see how that arrow shows you get a much better line of sight through the spaces of the approach and into the very back part of the lesion. So we're going to come from the left. There's our overview of the approach, and here's our view. So again, left-sided sylvian fissure split. All of this work begins with a very thorough sylvian fissure opening, because again, these are potential spaces that don't exist unless you open them up. So you have to open up these arachnoid layers. This is coming over the optic nerve. This allows the frontal lobe to peel back and open up that carotid cistern. So this is important, as is the splitting of the sylvian fissure. Brings you down to the optic chiasm here. And as we deepen, we're going to start to get into that carotid oculomotor triangle here. So here's the carotid artery, right in the center of our field. This is membrane of Lilliquist. This is now coming along the 3rd nerve. And as we release the 3rd nerve from the medial aspect of the temporal lobe, we can peel back the uncus. We can get into that carotid oculomotor triangle space more freely. And here now we're deepened all the way back to the level of the contralateral P1. There's the PCOM on the opposite side. This is the PCOM on the ipsilateral side. And once again, if you find that the PCOM is tethering things and closing off your window, there's no harm in taking it, particularly when it's small, like this one was. And now you can see we drop the shoulder of the P1. And this is now just releasing P1 from the mammillary body and ultimately getting across to that opposite side. So this is now looking at PCOM on the opposite side. And I'm looking to get into that interpeduncular fossa, but importantly, to cross over to the other side. So I follow my thalamoperforators into the interpeduncular fossa. And as I deepen into that space, you can start to see that hemosiderin stain from the malformation. So now I've gone through some of that scar tissue. The malformation was just below the surface there. You can see the classic mulberry there. And you'll notice how that contralateral trajectory to the other side is very easy to see. There's no blind corners. You get a straight line of sight into that deepest part of the cavity. And here, just working the malformation free. I'll take you to the end. We get to a nice clean cavity there, and there's that nice line of sight. So our overview here is being shown. The bifurcation of the basilar is there, the mammillary body being elevated, thalamoperforates working over the that bifurcation of the P1s. And here I'm just showing some superior hypophyseal branches to the underside of the optic nerve. Here showing the 3rd nerve, showing the pons, the overbelly of the pons, and our overview of the approach. So a very nice approach for this kid. And here's his post-op showing that finally, after 2 prior incomplete resections, I was finally able to cure this for him. So let me move along to the next approach. This is different, but very similar. This is for the peduncular lesions. So same orbitozygomatic approach, but instead of the transsylvian interpeduncular approach going medial to the 3rd nerve, this is a transsylvian peduncular approach going lateral to the 3rd nerve. So our working triangle has shifted from the carotid oculomotor triangle to the oculomotor tentorial triangle, which you see up in the upper right in purple. So different space. And if we need a safe entry zone for these lesions, it's the anterior mesencephalic safe entry zone, which you can see is on that medial 3rd of the cerebral peduncle. We stay medial to the descending corticospinal fibers, and we enter there. So let's go to the video for this. This was a 25-year-old, and you can see from this MRI that it sits right in the peduncle. It's no longer in the interpeduncular fossa. It's more lateral. And so we need to modify our approach slightly. It's on the left side, so we're going to go on the left again. Here's our overview showing frontal lobe to your right, temporal lobe to your left, and now going down into the carotid cistern. Now, for this one, you'll see that as I split the fissure, there's quite a venous complex here going into the bridging veins of the sphenoparietal sinus. And you've got to be very cognizant of these veins. You can see them here. And so what I'm doing here is a transposition of the sphenoparietal sinus. So I'm going to go extradural, and I'm going to mobilize that dura of the temporal pole here. And that's going to allow me to keep those veins connected to the sphenoparietal sinus, which then will mobilize them posteriorly and open up my surgical corridor and also keep the veins intact. So this is a very important trick. I don't use this often, but in cases like this, it's very important. So now I'm converting back from extradural to intradural. And in the process, I've preserved all of those superficial veins. It's opened up my window. This is a view of the PCOM and the anterior choroidal. So I'm going back into this carotid oculomotor triangle and now into the oculomotor tentorial triangle. So I'm working back and forth, medial and lateral to the third nerve, freeing up the perforators. And this is quite low in the midbrain. So you'll see that I'm going to have to jump into the triangle here and drop down. So this is now in the triangle lateral to the nerve. And as we get into that space and open it up, you can see now I'm below the superior cerebellar arteries. Those are in here. These are perforators to the midbrain and the upper pons. And there's the spot right there at my pointer and my instrument where the lesion comes to the surface right as the cerebral peduncle enters into that ponto mesencephalic sulcus. So this is our site of entry. And you can see by just widening that those fibers there, we enter into this hematoma cavity. And when there's fresh hematoma there, the blood clot can be evacuated and it creates working space to have access. So that's basically the exposure, a little bit different. I'll just take you to the end here, showing the clean resection cavity, the working view there. And again, we're dropping quite low, but it's using the full reach of that transsylvian exposure to get down to that level. All right. So the next one I want to show you is this one. This is the periaqueductal. And for this, we're going to use a bifrontal craniotomy. We're going to go interhemispheric, transcallosal, translateral ventricle, and then transchoroidal fissure into the third ventricle. And you can see from this illustration here, again by Peter Lawrence, how these lesions sit right around the funnel of the aqueduct here. So you really need to get into the foramen of Monroe, open up the choroidal fissure, and enlarge that opening so that you can extend it back. So here's an example of transcallosal, transchoroidal approach. Here's an example of that approach. And this was a really nice one. You can see from this, these MR images, how it's sitting right next to the origin of the aqueduct there in the third ventricle. It's floating in CSF. Our approach will be with a midline turned horizontal. I do this so that gravity can retract the dependent hemisphere and allow that fissure to open more widely. So let's jump ahead here to the dissection. This is opening up the interhemispheric fissure. The frontal lobe is sagging here on the lower part of your screen. The falx is on the upper part of your screen, and you can see now coming onto the corpus callosum. Here I'm getting through the ependema of the lateral ventricle and into the third ventricle, and this is where the challenging part comes. You see how the foramen of Monroe is in full view, but clearly it's too small to get to our lesion. So what we've got to do is extend our opening by going into the choroidal fissures. So I like to cauterize the choroid because it just shrinks it down and makes it more manageable. And that will lead you to this lateral edge of the fornix, the medial edge of the tuft of choroid, And in between is the tinea choroidea, which is the arachnoid layer that anchors the choroid to the fornix and makes that roof of the velum interpositum. Now, as we open this up, our foramen of Monroe has widened all the way back to here and has brought us to the point where we now see the malformation. So this is now direct line of sight down to the malformation. You can see it's a long reach, so it's a bit dark. That's why these lighted bipolar instruments are so nice, which you'll see here in just a minute. But we can pull the malformation into the that working corridor there. We can free it from its adhesions to the thalamus and see how I'm really working within the central portion of that third ventricular space. I don't have to go into the parenchyma much. You're going to get a nice view here shortly of the aqueduct, which is right here at the bottom of this. And I'm working this free from that medial thalamic tissue and that periaqueductal tissue just below it. So here's at the end, you can see a nice clean resection cavity. We're looking into the very back spaces of the third ventricle. I'm just exploring here, making sure I've gotten all of the little remnants that might remain. It's important to look for those little fragments like that one that could potentially be a recurrence. This here is the back of the third ventricle, where the pineal recess is located, and the aqueduct is just in this area here. This is now a view looking more forward into the third ventricle. You see the mammillary bodies, the tuber cinerarium here in the front floor of the third ventricle. And here's an overview now showing how that foramen of Monroe used to be here, opening the choroidal fissure, takes us all the way back to there. We've nicely preserved integrity of the fornix, as you see along there. And this has provided that working window with no transgression of tissue other than the corpus callosum. This is a very similar approach, so I think I'll skip that in the interest of time. And then one more one more brainstem cavernous malformation is the basilar one. So for the basilar ones, you can often expose these, or typically expose these with the Kawase approach, taking out that anterior petrous bone to lower the exposure further to get into that space below the fifth nerve and to the anterior surface of the pons. And that's really the way to get down to lesions that lie right around the origin of ICA underneath 5 and above 7 and 8. The territory of this subtype is really the basilar groove and the transolivary line, this portion in teal. And you can see that for this lesion, there really is no good safe entry zone because you've got corticospinal fibers right there. I'm going to show you this case, which is we didn't actually need the intrapeduncular faucet. We didn't actually need the Kawase aspect of this. You can see it's high enough up in the pons. It's in what I call that upper belly of the pons, where just by deepening our exposure, I was able to get to this. And let me just jump right to it. This is now a right-sided exposure, a transsylvian dissection here. This is working over the optic nerve. You've seen this, so I'm going to take the liberty of accelerating this a bit. Here we're working medial to the carotid into that carotid ocular motor space. Here is division of the membrane of Lilliquist. Here's the third nerve coming into view. And as we deepen down, we follow PCOM back to the PCA. And before I resort to any transcavernous conversion, I like to see if I can get away with just a simple transsylvian exposure. And you can see here that I can. The lesion comes to the surface right here on that upper portion of the pons. I'm in that oculomotor tentorial triangle. The malformation is right there on the surface. It was a very small working space. And, I'll just take you to the end again. You don't have a lot of panorama to look through, so you've got to work the malformation into your central part of your corridor to see everything. But with piecemeal resection and careful dissection, this came out. This was a PhD grad student at the Barrow, and he ended up doing perfectly and is now pursuing his postdoctoral studies. And I'll just show you his postoperative MR right there, which shows our complete resection and a good result for him. I'm close to my time limit. Do you have time for one more?
Sure.
Okay.
Okay.
Okay, sir.
So this one is just, it's a frontal approach. It's not technically a brainstem cavernous malformation, but these optic cavernomas are so rare, I thought I'd just throw this one in at the end. We just published our series of these, and I think there's a lot of intimidation operating in the optic nerve. So a lot of people manage these conservatively, but I just wanted to show you a case. We've had actually quite good results with our optic nerve cavernomas. And this is a great example. A young lady, she was previously operated endonasally at an outside institution. They thought this was a craniopharyngioma. You can see the lesion here. They ended up just grabbing a piece of it and backing out. And then they referred to us. And this is just a mini pterional approach. She's a young, beautiful girl. So I wanted to have cosmesis at the forefront. You can see the exposure here. And like the other cases I've been showing, if you do a really good Sylvian fissure dissection and open up that space and get yourself into the carotid cistern, you see how this cavernous malformation comes right to the surface. This is the optic nerve here around the patient's left side. And it comes right to that surface, and we can get right into the malformation by just going through this peel layer on top of the nerve. And so it's really important on these to preserve every nerve fiber you can. Every nerve fiber, in my mind, represents a piece of that visual field. So you want to really religiously stay inside of the capsule of the malformation. You also want to religiously preserve these perforating arteries that run along the surface of the optic apparatus, because perforator injuries, as we've learned from our ophthalmic aneurysms, can be costly. So here you'll see I'll open a second window so that I can preserve that little perforator there. And this gives us access to a different portion of the cavernous malformation. And using these instruments, you can free these various compartments. And again, here's the bulk of the optic apparatus. The malformation pushes the nerve fibers to the side so that if you stay in the center, you can work this free. You can identify those adhesions. You can free them up with careful dissection and ultimately work this all out of there. So here's our piecemeal dissection. You can see it's extending all the way over across the chiasm to that other side, but we are opening up a nice corridor here that allows us to mobilize the different pieces of the lesion in. And here, as we get to the end, we're starting to see clean cranial nerve margins here, which represent our complete resection. So here now, at the end, you can see our overview. This is the anterior cerebral artery. You can see the resection cavity there. This is looking over to the contralateral carotid. This is the optic nerve on the other side. Olfactory tract is up here. We've got this beautiful view across. This is the well-preserved optic nerve on the other side. You can see it reached all the way over to there. So it really was a chiasmatic lesion. And just by staying inside the borders of the malformation, we're able to chase it all out. And it's a matter of working through all these different triangles. We've got our interoptic triangle, our carotid optic triangle, our pre-communicating triangle. All of the triangles that we use for our aneurysms, we can use for the cavernous malformations. So I'm going to skip this. These just summarize the approaches that you've seen. I like to think of the arteries as our trail guides. You can get on these arterial landmarks. You can follow them, whether it's an interpeduncular cavernous malformation. You can use the arteries as your trail guide. They will lead you from the Sylvian fissure at the M3 segment all the way down to these other arterial segments. You can use the branches, and they'll literally follow, take you as if leading you through the wilderness to the malformation here. Same with the peduncular lesions. Again, following the MCA branches down to the PCOM and the anterior choroidal artery, following them back to the P1 and the P2, and directly to the lesion. So I'm going to stop there. I have put all this stuff out there in JNS and the 7 Cavernomas collection. There's so much more that goes with this, with all the different clinical signs and symptoms and syndromes. Hopefully, you're seeing that, reading that, and enjoying it. And the reason for this is that I think if we talk in the same language about these malformations and not just put them in one big bucket, but break them down, then we'll just be able to really refine our knowledge and ultimately make the right decisions on approaches and management and improve our outcomes. So thank you so much.
Thanks a lot, Defend, for this amazing, excellent presentation. And thank you also for saving this time from your vacation time. And now, Professor Ibrahim, please go ahead.
Yeah, Michael, thank you very much for this brilliant presentation. You're just making my life difficult to follow your presentation. But I have a few questions.
Sorry about that.
Thank you. I want to ask a few questions. The case that you showed us with the cavernoma of the optic nerve reminds me with the case that we published recently in the interdisciplinary neurosurgery about a cavernoma in the optic chiasm itself. As you said, one has to preserve every tiny fiber there and every tiny vessel there. My question for you is, do you follow a stain in the cavity, or do you just settle for the white stuff of the brainstem? Can you unmute, please?
You are muted.
There we go. I think if you're asking, do I get every last bit of the cavernous malformation out and take out some of the stained tissue adjacent to it? The answer is no. In the brainstem and in the optic nerve, every little piece of tissue I think is valuable. So I leave the gliotic, hemosiderin stained tissue because I think it's too critical. You just can't afford to get into that. Even just a fraction of a millimeter can be costly in terms of a nerve nucleus or a tract. So I limit myself just to the pathology or the mulberry, so to speak.
And when you cut the PCOM in some of the cases you've shown us, do you have any precautions there? Do you care whether it is a hypoplastic PCOM or a dominant PCOM? Yeah,
it's a great point. You cannot cut a fetal PCA for obvious reasons, but if it's a PCOM and you have an intact P1 and P2, there really is no reason you can't take a PCOM. It will compromise their collateral flow. So if, for example, you do an endarterectomy on that patient in the future, or if they have a carotid occlusion in the future, they may not be as tolerant of that, but it has no clinical significance at the present.
And regarding the sphenoparietal sinus, you showed very good a trick, which I sometimes also use, is just cut the dura around it and so on. Did you face any problems with just one case where you sacrificed the sphenoparietal sinus?
Well, it's as you know, it's a judgment call. You can sometimes sacrifice those veins and get away with it. Other times you can't, and there's no way to know, at least in my mind. I've never found a predictive algorithm for that. So, it's really just how big are they? How important do they look? Are they dominant? I look at the other venous connections. Sometimes if you have a big anterior bridging vein that goes to sphenoparietal sinus, but you've got connections to vein of Labbe posteriorly or vein of Trollard posteriorly, then even though it's big, you can take it. But if you see everything channeling forward and you have no collateral connections in the back, then I think you need to resort to the transposition maneuver. Because, if you take it and you get a venous infarction, then you can't take that back. And if you just take the extra 10 minutes to transition epidurally and mobilize the dura, it's not, it's a complicated maneuver conceptually, but once you do it a time or two, it becomes very easy to understand and do. So I think it's just a matter of a little time in the cadaver lab and people getting familiar with that. It's a very valuable.
My last question is about the transchoroidal approach when you go through the tena choroidi, etc. This reminds me of the Michael Apposo old-fashioned approach, which he said that it will cause lots of memory disturbances. Did you face any of that?
Yeah, well, so Apposo was a big fan of the interfornicile approach, and the beauty of the interfornicile approach is that it's so orthogonal for our simple-minded thinking. So all your anatomy is square and you can go right down the center. This is not that approach. This is not an interforniceal approach. It's a transchoroidal, which means it's off the midline. You're going under one of the fornices, not working or manipulating both. So the contralateral fornix is totally untouched. The ipsilateral fornix, if you take really good care of it, you're not going to have memory deficits. The key is to get into the tinea choroidea. And then also, once you get the plane starting to open up, what I do is I take a thin delicate or cottonoid and lay it across the fornix so that as the plane opens up, you then put some padding on the fornix so that any manipulation, because you do have to lift it a little bit, any manipulation is not going to be injurious to the tissue. It's just going to be transmitted by the cottonoid. So that to me has been the best way to manage the fornix.
Thank you very much indeed. As I said, you'll make my life difficult presenting after you. Thank you for this very brilliant presentation.
Thank you for your questions.
Thank you.
Thank you, Professor Lawton. There is one question in chat box asking about timing of attacking bleeding malformation.
Sorry, can you repeat the question?
Timing of attacking bleeding malformation. When you attack bleeding malformation.
Oh, when do I attack the bleeding malformation? Yeah, okay. So I like to operate on these in the acute setting, but not the hyperacute setting. So in other words, in my mind, that 0 to 3 week window is what I call acute. And if you can get a patient who is, beyond that first week, in that second and third week, the hematoma has liquefied, the tissues have settled down, and you can really use the liquefied hematoma to your advantage to operate. The subacute period, in other words, from 3 weeks to 8 weeks, is also a nice window to operate. But if you get beyond 8 weeks or 2 months, what happens is that hematoma, it's already past its liquefaction, it's starting to reabsorb, and the malformation can start to scar. And so it becomes a lot harder to separate it from brainstem tissue. So I do think there's a little bit of urgency, but on the flip side, if you operate too early and you're dealing with a very edematous brainstem, and also if you've got thick clot that is all around the malformation, it can sometimes be harder to operate under those circumstances. So I think the optimal window is somewhere between 1 week and 8 weeks. And it just depends. Like for my practice, I have such a long distance referral pattern that I usually don't see these in the hyperacute or even the acute setting. I usually see them at about, usually they come to the office a couple weeks after their ictus, and then by the time we arrange surgery, it's in that subacute window. So I think that's a really nice time to do these.
Okay, another question from chat box asking about when you sacrifice BCOM.
Those videos that I showed you were a nice example. There's a relationship between the PCA and the carotid, and that PCOM tethers or pulls them together. So if you find that you just can't get the opening that you need, cutting the PCOM allows them to spring apart, and it's a dramatic difference. And if you don't recognize that you're pulling on the PCOM, you can avulse it. And if you leave it to that point and you've avulsed the PCOM, you've got a hole in one of those arteries. It's usually the PCA, and that's a lot harder to control. So you're better off getting ahead of it and sacrificing it exactly where you want to, which is between perforators, and it's of no consequence. One of the first things I learned in vascular surgery was that you don't need an intact circle of Willis. Nature has taught us that as well. And the places where you can divide it are PCOM and A1. And so that's just us taking advantage of that anatomy for surgical purpose.
Okay, is there a question from panelists? My last question about strategies. How much strategy do you build before surgery? As we know, not every surgery goes as we need or as we have expected to be. So when will you change your strategy, or when did you experience fail of strategies?
Yeah, I think what you're asking is if I got a bad outcome, how do I deal with it? Is that your question?
Yes.
Yeah. Well, okay. Yeah, I mean that's a tough one because I think anyone who's operated in the brainstem knows that we go in with a lot of optimism and a lot of high expectations, and it doesn't always work out. If you read Dr. Spetzler's papers on brainstem cavernous malformations, his temporary morbidity rate was, I think, 45%. That's a really hard way to make a living, knowing that at least in the short term, you're going to make almost half of your patients worse. I have found that, it's my number's not that big, but it's still up there, and it's hard because, sometimes you have a patient immediately post-operatively who's been set back. And I think that's where it just takes a lot of continued optimism and working with the family to get them through. We have a wonderful rehab program for some of our patients who go through that. But I also think, to not have to deal with that is just to emphasize what I said in the talk, which is when you take these things out, if you get inside the lesion and work within the capsule, then that's your natural protective barrier to morbidity, postoperative morbidity. And so I try and take as much of the malformation out from the inside and not get on the outside of that capsule. So, in theory, if you can get to a lesion that's right on the surface and stay within the capsule, you may never have to touch the brainstem because you're, in theory, just working internally. And I think that's the way, at least in my mind, I think about it. It gives me comfort to know that I'm inside pathology rather than inside brainstem.
Michael?
Okay, possible.
Yeah.
Hi, Vladimir.
Hi. Two simple questions. Do you check the cavity with the endoscope?
It's a really good question because, it makes a lot of sense. But in reality, I've found the endoscope to be underwhelming. You're looking for blind corners. We published a paper about a year ago on our residual brainstem cavernous malformations. And I think the take home in my mind was it's more important as surgeons for us to think about it strategically, like where is that remnant going to be? And we came up with what I call the right angle rule, which is if you're looking down the axis of your corridor into the lesion, think about where at a right angle to that axis you're going to have the hardest time seeing. And it's usually in the near corner at right angles, and it's at the spot where you're furthest off the axis. And if you're thinking through this and you go deliberately to that point, you'll find your residuals manually by just manipulating the tissue, changing the microscope view. You'll be much more successful than if you pull on the endoscope. Because what I find is that by the time you get the endoscope in, you're down a long corridor, you're through the keyhole of your opening, you're trying to look around a corner, and you can't really see what you're trying to see because it's only an eye. You can't feel the tissues, you can't brush up against them and see if there's some sort of a haptic change or a textural change, and you really need that. So I have not relied on the endoscope.
Yeah, great to hear that. And another question, majority of these cavernous malformations do have DVA. In one of your cases, you had the DVA in the posterior aspect of your cavernoma. Do you check for that prior to surgery, and were there a case which would alter your approach?
Yeah, the DVAs are ever present. I forget what our number is, but it's more than 50%, either a DVA or a frank venous malformation. So they're going to be there. I follow the dogma of preserving them. They can alter the approach. If you have a big caput medusa or big trunk that's right in the middle between you and the lesion, like the great example is those, you've seen them, the DVAs that are on the floor of the fourth ventricle, and you're trying to get to the pons on the other side. That's a real problem. And sometimes it will alter my approach, and I'll choose a more lateral, say a trans MCP approach instead. So you do have to factor it in. You do have to save those. But I would say overall, it doesn't really change the surgical decisions that I laid out there. I think you still adhere to the approach selection and the dissection technique. I have a theory about DVAs, and that is, when you do have calf mals that have a big DVA, they tend to bleed more, I think, during the resection than if you don't have a big DVA. So it does make it a little bit more anxiety provoking and bloody, frankly. So you don't get that nice clean dry resection that you sometimes get without a DVA. So I haven't proven that. It's a hard thing to prove, but I think there's a factor there that's important.
Okay, thanks. Thank you.
Thank you. Thanks a lot, Professor Lawton. I really appreciate your attendance and saving this time for us from your vacation time, and see you soon, dear friend.
Well, thank you for including me, and thanks for letting me go at a time that's not in the middle of the night for me.
Thank you, sir. Thank you. And now we will shift to next speaker, Professor Neurosurgery. Please start sharing your screen.
Thank you much. Thank you, Sam. Thank you, John. It's been a long time since we joined together. And thank you, Michael, again for this very brilliant presentation. And as I said, you are going to make my life difficult, but the information and the beauty of the presentation, I can actually take this out completely. I hope you'll stay with us, because I'd like to hear your views at the end of it of this this approach that I'm going to present. I'm from Amman, Jordan. And the approach I'm going to discuss is the fronto-basal interhemispheric translaminar terminalis for regions within and around the third ventricle. So let's speak a little bit about lamina terminalis anatomy. It's a layer, it's a plate, and it's a forebrain structure in the anterior wall of the third ventricle. It's made of gray matter, pia matter, and ependyma. With most of the area of the lamina terminalis is devoid of neural tissue or neural cells. This is just to remind you of the relationship between the thalamus and the hypothalamus. And again, we'll go to the anterior wall of the third ventricle, starting from above, from the fornix, and then coming to the foramen of Monro, anterior commissure, lamina terminalis, and then the rhesus, optic rhesus, and the optic chiasm. This is the anterior wall of the third ventricle, and lamina terminalis takes part of it. So again, the anterior commissure here and the rhesus of the optic chiasm. So this is the area of the lamina terminalis. So as I said, if you look at the anterior wall, fornix, foramen of Monro, anterior commissure, lamina terminalis, optic rhesus, and optic chiasm. Again, showing here the lamina terminalis and the cistern of the lamina terminalis, which contains lots of vessels, A1, A2, veins and arteries, artery and vein, recurrent artery of Hubner, frontal orbital arteries, subcallosal artery, and the hypothalamic perforators. Papers written about the anatomy of the lamina terminalis is a very beautiful paper by Francesco Tomasello, my friend from Italy, about the anatomy of the lamina terminalis. He described it as a rhomboid, and he measured in very cadaveric cases the average length. So A distance is about 8 to about 10 millimeters, while the B distance is about 12, 13 to 19 millimeters. So surface area is not that big, but it is big enough to go through it. Another paper by Wang, 2011, about the anatomy of the lamina terminalis, and he showed these pictures in his paper. If you remove the blood vessels there, then you come to the arachnoid covering the lamina, and then if you open the lamina, you'll get into the rhesus and into the cavity of the third ventricle. Another beautiful paper also, 2019, Anatomy of Lamina Terminalis. It's in the Anatomy Journal of Africa, beautiful paper showing that the lamina can have various degrees of translucency. So this is a very translucent, this is a little bit dull, this is completely opaque. And this is the 3D anatomy of the lamina terminalis which is the anterior wall of the third ventricle, and around it, the hypothalamus with its nuclei, which are arranged into three groups: anterior, middle, and posterior group from anterior to posterior. And also they are arranged periventricular, paraventricular, and lateral. So these nuclei are around there, and this is fraught with fear to go into the hypothalamus. The lamina terminalis approach that I'm going to describe, was used in the past. I remember lots of papers by Neurosurgical about how to use the to open the lamina terminalis to wash the blood of the subarachnoid space. Suzuki also described this. These are the list of people who describe the lamina terminalis approach since then. This is a paper by Mitch Berger about the bifrontal olfactory nerve sparing approach to lesions of suprasellar region in children. And this is important because you save the olfaction. Another paper from USA about the lamina terminalis approach, and another paper from Japan describing this frontobasal interhemispheric approach to the lamina terminalis. Another paper from China, 309 patients, they used lamina terminalis approach in 55% of their patients. And from Japan also the bifrontal basal interhemispheric approach. Frontobasal interhemispheric translaminar was also described by Amir Dashiti and Triboulet from France. I'm going to describe now my experience with this lamina terminalis approach. Approaching the lamina terminalis via terional approach. I found this was a paper published a long time ago, in 2000, the year 2000. And when I use the terional approach to reach to the lamina terminalis, there are always blind spots there. So I suffered a lot to change my mind to go from terional approach. This is one of my terional approaches. You find difficulty to reach to the lamina terminalis there. All the pictures I'm going to show are cases of mine. So I shifted to the frontobasal interhemispheric. I'm going to show you my personal experience with that. Lots of third ventricular lesions that I have in the third ventricle where I use the lamina terminalis approach. Some of them here is shown in teratoma, histiocytosis, glioma, optic nerve, astrocytomas, meningiomas, and choroid plexus papilloma. One case is histiocytic sarcoma in this child from Syria, which was successfully removed through this lamina terminalis approach. Pilocytic astrocytoma of the third ventricle, again, removed successfully through the lamina terminalis approach. This giant optic nerve glioma was removed through the same approach. And the hamartoma, this was a young boy, I think 1.5 years, with the precocious property, large genitalia that we removed through the same approach. Germinomas also been removed through the lamina terminalis approach. This very unique case of immature teratoma from Bahrain came to my way, and I removed it through the lamina terminalis. Very recently, last I think 2 weeks ago, I operated on this case of astroblastoma. I have now 5 cases of astroblastomas that I removed through the lamina terminalis approach, very rare tumor. So steps of surgery in my experience, we use this craniotomy flap by coronal. I cut the most anterior part of the severosagittal sinus. I go and cut the forks and then go interhemispheric and reach to the chiasm. I preserve the olfaction. In all my cases, I preserve the both olfactory tracts, but does not mean that olfaction will stay in. About 85% they keep their olfaction, and 15% they lose it in spite of preservation of the anatomy of the olfactory tracts. This is the view that you get: optic nerve, the chiasm, gyrus rectus both ways here. Again, olfactory olfaction preservation, reaching to the optic chiasm and to the lamina terminalis. Sometimes you'll find that the chiasm itself is infiltrated. As I said, these are all still pictures of my cases. I just avoided to use a video because it's time consuming, so I just replaced them with this still pictures. This is a view of the chiasm and how the tumor invaded and ate lots of the optic chiasm and the tract. You can see A1, A2, and they come here. It was a fenestrated type of variation that was mentioned in the Neurosurgical book. So when you reach there, you have different views of lamina terminalis. I'm showing you different surgeries, different patients. So this is one of them. This is the view of the lamina terminalis. This is another case of where the tumor just bulged through the lamina terminalis. Again, here you observe that we have preserved the olfaction on both sides, and then here is you find a very vascular area of the lamina terminalis and open it. So different variations of how you come across the lamina terminalis. Here it's very narrow lamina terminalis. Here it is just tumor is bulging through the lamina terminalis. We open the lamina terminalis, and what you get is the fluid of the tumor. If it is there, if it's a craniofaryngoma, for example. Another case, when we open, we also get the turbid oil-like fluid of the tumor in case of craniofaryngomas. And then you start dissecting the tumor. And different cases will show you how do we dissect it. I believe that you can find an area of gliosis that differentiate between the tumor and the chiasm, the tract, and the wall of the hypothalamus and the midbrain. So this is the way to do it, to find this plane of cleavage, different kinds of tumors. Here you can see that we found it, the cleavage line. Here the tumor is being removed, and the stalk has been preserved, the olfaction has been preserved. Here you can see the basilar artery in the bottom there with the deliquescent membrane. Again, here to find the good plane of cleavage to remove the tumor. And I don't hesitate in using the ultrasonic aspirator because some of these cases you really have very hard calcification. So I'm not reluctant to do that. And as I said, you can find a plane of cleavage. You can see the walls of the hypothalamus in the bottom and on the sides. Here you can see that I put a patty there to differentiate. And then you can reach to the mammillary bodies. And you can see the midbrain here. And you can see the deliquescent membrane. So it can give you, this approach is very versatile. It gives you the approach to be no blind spots at all in the center. You can go right, you can go left, you can go to the opticocarotid triangles to remove tumors from there. If the stalk is a tumorous, I don't hesitate a second in removing it because it is tumorous. It will just calling for recurrence. So I cut it and dissect the tumor in front of the chiasm and in the back of the chiasm. I just manipulate it to get a good total resection of the tumor. I go for radical excision of these tumors whenever I can. If the stalk is not involved, so I preserve it. Here the tumor is lying on top of the stalk, but still one can really find a plane of the cleavage, dissect it, and remove the tumor off the stalk that was attached in here. And you can see here the basilar and its terminal terminal branches. Vascular structures here, you can see the basilar artery through the lamina terminalis. You can see the deliquescent here. And here, again, you can see the terminal branches. Different cases, the same views almost. So here you can see on the left side, you can see the stalk here, the optic nerve and the carotid. So if there is a need, I can go in here. On the left side, I can go on the other side, on the right side. So I am really in control on the driving seat, central and left, right, and anterior and posterior. I just given you an example of this approach in my craniofaryngoma cases, 114 cases. Mostly they are solid or mixed, but the thing about these cases that they are giant, more than 4 centimeters, 74 cases. In my part of the world, we only get those in very large sizes. Jordan is only 10 million population with all the refugees that came from Syria and Iraq, but still I get lots of these cases being referred from the different areas of the Middle East because Jordan is a medical hub of the area. Gross total section using this approach was achieved in the cases. I classified them into adults and children, mostly of course children, 66 cases. So this is my personal series. I will show you some cases of the adults This was a case that was referred to me from Bahrain. This lady, 73, with this huge tumor. She was operated at St. Elsewhere, and they went to the transsphenoidal there. But what they get is to injure the carotid within the cavernous sinus, and she came with this aneurysm. So what we did is to neutralize her aneurysm first, and then we went in and removed the tumor via lamina terminalis, and she went back home safe and well. Another case, 30-year-old male patient, sorry, with this tumor, a large, huge tumor, female, yes, from Libya. Female from Libya. She's a wife of a doctor there. Again, removing the tumor completely. And you wonder now, looking at the post-operative, where is the floor of the third ventricle? What is the hypothalamus? It's been pushed aside, and this has been shown in so many studies that these tumors actually, they pull the mammary bodies to the sides. So you are safe to go there. You should not be afraid to go after these tumors for radical excision. This young man came to me from United Arab Emirates, a 24-year-old with this extensive craniopharyngioma. I again went in and removed it completely with the long follow-up. Another case, 25 from Libya, with this tumor extending from foramen of Monroe to the foramen magnum. Again, using this approach, lamina terminalis, you can pull the tumor. And I found this, that the attachment of the posterior fossa fractures to craniopharyngioma is far less than supratentorially or above the chiasm. So this tumor has been removed through this approach. And this actually was a long time ago, about 20 years ago. I noticed that when you use this approach, people are afraid of obesity. And my observation is that in the adult group, I did not see any obesity in the adults. It was 0%. So there's no fear of the obesity, which makes everybody afraid of going for radical excision. In adults, these are the photos before and after the long follow-up of the cases. I did not see any obesity following radical resection via lamina terminalis of these craniopharyngiomas. Again, this long follow-up of this patient from Bahrain, and this lady from, I think, from Iraq, and this patient from 18-year-old from Sudan. No obesity in the adult group at all. In the pediatric group, yes, some of the cases, and we'll discuss the obesity issue. This was one of the giants of the craniopharyngioma. I call it Hiroshima Hiroshima and Nagasaki kind of craniopharyngioma because of this fungus appearance. And again, the radical excision of the tumor. And this radical excision of this very extensive complex kind of craniopharyngioma, and 12-year-old female patient who went well. And this is the story of my life. This is the boy I operated upon in the year 2000. He was just, I think, a year or two. Radically excise a tumor. When you radically excise them, you don't need to give them radiotherapy. You don't need to give them chemotherapy. So that is something that I cherish very much. So follow him up through the years, 2003, 5, 7, 9, 12, 13, 14, 17, nothing, no recurrence whatsoever. He did not receive any radiation, nothing. And this is year 2020, a young man who went to the college. That's given me lots of the pride. So the new onset obesity in children, yes, it happens. It happens in 60% of my series, but mind you, 80%, they disappear after 3 to 4 years. I'll show you. So here you are some of these cases of pediatric obesity that people are afraid of. It usually disappears within 3 to 4 years. And this is a very interesting case. Look at her getting obese and then transforming into this young, beautiful young lady. Again, this case, this patient from Yemen and this patient from Syria. Again, this young female, no obesity. obesity and then disappears. And another case. The complications of this translaminar terminalis approach. I had two in cases of the craniopharyngioma series. I had 2 cases out of 114 as a mortality. I show you one case who was actually operated upon in Saudi Arabia with this. This is the craniotomy. They did not just puncture the cyst, and they referred him for radiotherapy. He came my way, and I said, no, we have to go for excision. Excised the tumor completely, but he showed a slow deterioration and died on the 7th post-operative day. Another case came from Iraq with this extensive craniopharyngioma. I also excised her tumor completely, but she died on the 18th post-operative day due to pulmonary embolism following a DVT. So the quality of life in my series of 114 using the laminar terminalis and others, mostly they show independent without impairment. 11 independent with impairment, or partially dependent and totally dependent. Regarding the vision, post-operative visual, it improved in most of the cases. I have one case of worsening of the vision, and I have my share of the injuries. I had one vascular injury of the intracranial carotid, hydrocephalus in 2, CSF meningitis, like any other series. Regarding the endocrinological outcome, the most of them, they have partial hypopituitarism or DI. Most of the cases, they are worsened from the endocrinological point of view, and then gradually they improve. So that should not stop us from doing radical excision of the tumor. Histology, we do all kinds of slides and stains for the tumors. We use all kinds of immunostaining, and we published our series about differential expression of immunohistochemistry markers for epithelial squamous cell in adenocarcinoma, craniopharyngioma, in the International Clinical Pathology American Journal. Last slide here is this case of this tumor. And again, just to show you post-operative, you may say, well, where is the hypothalamus there? This is mammillary body, part of the floor, and then nothing there. This means that the patient should be bad, but actually they are extremely well. So I'm not looking just for a good MRI. I'm looking for a good MRI with a good neurological and endocrinological status. Again here, where is the floor of the hypothalamus? With this, I finish, and I thank you for your patience on me. The anatomy and extent of the tumor dictates the approach, but I believe that laminar terminalis approach is an excellent one for allowing radical excision, preservation of the neurovascular structures, and minimizing complications, and decreasing the problems associated with recurrences. People speak about fearing radical excision. I think one should fear the partial excision and the following radiotherapy, recurrences, shunts, and revisions of shunts. Thank you again.
Thanks a lot, Professor, for this excellent presentation. Is there any question from panelists?
Dear Dr. Imran, hi, how are you? Congratulations for the talk. It's amazing cases and very beautiful approach and a new way of being challenging these lesions. I wonder if you had ever put an endoscope through this approach just to see the final the final view of surgery, looking for residues of tumor, because we had a case of an adenoma. There was a pituitary adenoma that went through the third ventricle, up into the third ventricle, and then we could put the endoscope, but through the transsphenoidal approach, and then transfrontal approach, but from down up, and we could go through the laminar terminalis, and we had a good view with the endoscope. It was a very nice view and different point of view of this anatomy. So I wonder if you had any experience or thought about this.
Thank you for your question. The short and simple answer to your question is no, because with the laminar terminalis, I can see the walls clearly. I don't need an endoscope to see the blind spots. There are no blind spots in the laminar terminalis approach once you go through the interhemispheric approach. You see it central, you see it right, left, you see it anterior and posterior. So no, I've never done that in the laminar terminalis.
Thank you.
Thank you.
There is one question in chat box asking about your experience with radiated cases in this approach.
Yes, I've had the experience of operating on radiated cases. They make your life difficult, but this is not impossible. You still can find a plane of cleavage. With the adhesions, it is difficult, but being patient, then you can actually reach. And I always show a picture of my assistants falling asleep in the theater after 10 or 12 hours of working. Simply, these surgeries need patience, they need perseverance, they need to sacrifice your time for the patients to give them the best chance first time.
Thanks a lot, Boso, for excellent presentation. Is there any other question?
Yes, there is, Sam. Do you see it?
Dr. Muhammad?
Yes, Gang Bot.
Please ask your question.
Any cognitive issues with this patient?
Any
Problem.
cognitive
Issues in the long term?
terminalis? Not at all,
No.
not at all. I've never had any case of cognitive dysfunction and through the lamina terminalis approach.
Thank you.
We have one question from Gyan Bot. Would you recommend this technique for pituitary tumors with significant intraventricular component?
Definitely, I do. Yes. Yes.
Okay, thank you, Professor Ibrahim.
Thank
And now
you.
we will shift to next speaker, Professor Abida Shah. Please start sharing your screen.
Rivas, creo que Rivas es el que va a dar la siguiente ponencia. Creo que sí, pero no puede compartirla.
Lita, are you okay?
Yeah, just a minute.
Okay.
Ah, es este cuate es, no sé si sea mujer o hombre, güey, por el nombre no sé, cabrón. Pero hay que muscularlo. Vea que tiene más facciones. ¿Es hindú? Es hindú, güey.
John?
Yes.
John?
Yes.
I'm going to log out and log in again. There is some
Okay,
problem. Give me a
we'll be
minute.
here. We'll be here.
Mira, vamos a poner.
Okay.
No sé.
Okay, Dr. Rivas,
Mohammed.
are you ready to start sharing your screen?
Let me just open.
Salió.
I'm ready if you want me to take his place and change the order, but if you want to, I'm okay with time. It's
Okay,
up to you.
please go ahead.
Okay. So first, thank you for this invitation to participate at this amazing lecture with nice pictures. Thank you to be with all of you and to have this opportunity to teach. I was invited to talk about the frontal lobe anatomy and how we can use this anatomy to approach frontal lesions. Okay. So just you can see my my screen, right?
Yes, perfect.
Okay, thank you, Dr. John. So, what is the frontal lobe? In the beginning, we used to use cranial landmarks to divide the lobes, the brain into lobes. And at this point, we were using the coronal suture to distinguish what was anterior, what was the frontal lobe, and posterior, the parietal lobe. Then, historically, we began to understand more the anatomy of the brain and began to use brain surface anatomy with landmarks to divide the brain into its lobes. Nowadays, we see each hemisphere like having 4 lobes on its surface, and then 2 other lobes on its inside. So at its surface, we'll use the central sulcus to distinguish the frontal lobe anteriorly from the parietal lobe posteriorly. We will use the Sylvian fissure to distinguish frontal lobe and parietal lobes superiorly from the temporal lobe inferiorly. And then we'll draw an imaginary line that will extend from the parietal occipital fissure towards the preoccipital notch to distinguish the occipital lobe posteriorly. And most groups will use the midpoint of this imaginary line and connect this midpoint to the end of the Sylvian fissure to draw this small line here. So we'll have at the lateral aspect of the brain, we'll have 4 cerebral lobes, and deep inside we have the insular lobe that's deep inside the Sylvian fissure, that's the 5th cerebral lobe, and the limbic lobe around the thalamus itself. So let's understand these 2 important surface anatomy to distinguish what is the frontal lobe. First, we'll look for the central sulcus. We'll have 3 main clues, tenets to see which is the central sulcus. So the central sulcus, it's an oblique sulcus. This is the first clue. It's not really vertical. It's oblique. It's more superior aspect. It's more posterior than its inferior aspect, so it's oblique. Then it's a more continuous sulcus, differently from the pre and post central sulcus, which are usually interrupted, which are always interrupted because the frontal gyri will connect to the pre-central gyrus, and these connections will make interruptions at the pre-central sulcus. Likewise, the post-central gyrus will connect to the parietal lobus, and these connections will interrupt the post-central sulcus. So the central sulcus will be distinguished by being a more continuous and uninterrupted sulcus. So this is, and it's also a more isolated sulcus in the meaning that it usually does not receive sulci from anteriorly or posteriorly. So we have these 3 clues. It's oblique, it's continuous, and it's usually solitary in the way that it does not receive any other sulci. The other important landmark here is the Sylvian fissure. The Sylvian fissure is a wide cleft between the frontal and parietal lobe superiorly from the temporal lobe inferiorly. This is actually the lateral extension of the Sylvian fissure, but of course we need to understand the ventral extension of the Sylvian fissure, also called the Sylvian stem. This is a magnified vision of this stem. This stem will come from the carotid cistern lateral to the limine insula, and this stem will also divide the frontal lobe superiorly from the temporal lobe inferiorly. If we see the lateral extension, the opercula will embrace superiorly and inferiorly the Sylvian fissure, and we can see that the Sylvian fissure, the opercula, is made by a lot of convolutions. At this talk here, I'm just going to pinpoint the convolutions that make the frontal lobe. So we have the anterior Sylvian point. This is where the stem reaches its most lateral aspect. And from this point, we have 2 small sulci that arise from there. The more anterior one is the horizontal branch, and the superior one is the anterior ascending branch. Since both arise from the same point, they will distinguish a triangular part, which is called the pars triangularis. Anteriorly, we have the pars orbitalis, and posteriorly, we have the pars opercularis. The pars opercularis is naturally the connection of the inferior frontal gyrus to the precentral gyrus, and we will see this in other anatomy as well. This book has almost 100 years, and it already remember us about the lack of consistency between different people. We have different morphology, brain morphology into different people. So here we have a more traditional view of the pars triangularis, but here where would be the pars triangularis, much more retracted here from the anterior Sylvian point, and this passing here even more retracted, where would be the the triangular part. So we have to remember that this surface anatomy, it can be uneven, uniform between among us, but it has a certain organization. So in each surface, the brain has a basic organization that all brains, all hemispheres will follow. So we have a basic plan from the lateral surface, from the mesial surface, and from the inferior surface. Let's see this basic plan for the frontal lobe. What we can see is that we have 3 horizontal gyri, and they will meet anteriorly into the frontal pole. So we have the 3 gyri meeting anteriorly into the pole. Since they are 3 frontal gyri, they will be named superior, middle, and inferior. All frontal gyri will connect to the precentral gyrus, making these connection arms called in French the pli de passage. They will connect them together. These connections make the precentral sulcus being interrupted. Okay, and these connections are what connections here. Okay, so if we see this in another specimen here, we can also see the superior frontal gyrus connecting to the precentral gyrus, middle frontal gyrus connecting to the precentral gyrus, and inferior frontal gyrus connecting also to the precentral gyrus. And posteriorly, we have the central sulcus with these 3 common aspects. It's continuous, it's oblique, and it's solitary, in the meaning that it usually does not receive sulci from anteriorly or posteriorly. This is another hemisphere where all these aspects will maintain. So you see the superior frontal gyrus connecting to the precentral gyrus, middle frontal gyrus connecting to the precentral gyrus, and inferior frontal gyrus connecting to the precentral gyrus as well. To remember that the pre and post central gyri and its sulci are oblique, in the meaning that its more superior points are more posteriorly than their most inferior aspects. They are oblique. The frontal orbital region, also called frontal basal region, is distinguished by an H-shaped sulcus that's hardly seen. Perhaps more than half of times we don't see the H shape dividing the orbital gyri between themselves, but in some cases we'll see what resembles an H shape. But just for us to remember that there are orbital gyri, there are anterior, posterior, lateral, and medial. Medial to them, we have the optic tract inside the olfactory tract inside the olfactory sulcus, and more immediately the rectus gyrus, and midline directly medial to this. This is another specimen. The H shape is not seen here. We can see him as an X. Here we see the letter Y upside down, but just for us to remember that the orbital gyri are divided between anterior, posterior, lateral, and medial. And the rectus, this is the medial view of the frontal lobe. We can see the corpus callosum medially. It's not part of the frontal lobe, but it's really nicely seen. What is embracing superiorly the corpus callosum is the is a limbic component. It's the cingulate gyrus, and the cingulate gyrus inferiorly to the rostrum, it connects to the rectus gyrus, making the pole here that some people call the cingulate pole. Actually, you would call the cingulate pole, and then more anteriorly the rectus gyrus. The rectus gyrus is divided from the cingulate gyrus from the superior rostral sulcus and harbors the inferior rostral sulcus. The rectal gyrus continues itself superior and posteriorly into the frontal superior frontal gyrus, and between the superior frontal gyrus and cingulate gyrus, we'll have the cingulate sulcus. The cingulate sulcus posteriorly ascends, marking being the ascending branch of the cingulate gyrus, the cingulate sulcus, and marking the posterior aspect of the paracentral lobule. The paracentral lobule is in fact the pre and post central gyrus. Anterior is the pre-central gyrus related to the movement of the leg, and posteriorly the sensory motor area of the leg as well. This surface anatomy has been reviewed by several authors, and you can see these all spread on the literature. And this anatomy is important for the neurosurgeon since the development of microneurosurgery, especially with Professor Yasha Gill, using the sulci as the main corridors to approach deep lesions and deep compartments of the brain. And we'll talk about using these frontal sulci and these cisterns to approach frontal lesions. Now, what is inside the frontal lobe? Let's do a white matter fiber dissection. When we first decorticate the brain, we remove the gray matter, we'll see the first subicortical layer. The first subicortical layer is made by U fibers. These U fibers are short association fibers connecting gyri that are next to themselves. More inferiorly, we see a very big fascicle. It's called the superior longitudinal fascicle. The superior longitudinal fascicle is in fact divided into several fasciculi. The most medial one is a direct connection between the frontal and posterior temporal lobe. It's called the arcade fascicle. This is the one that people usually remember, but the most superficial ones are shorter, and we have a more horizontal one connecting frontal to parietal lobes, and we have a vertical one connecting parietal to temporal lobes. These are also called the indirect components of the superior longitudinal fascicle. Everything here is called superior longitudinal fascicle. And so people will even go further to be dividing the superior longitudinal fascicle, the horizontal components, into 3 parts, each one related to a different frontal and parietal regions. And as you can see, broadly, SLF1 is deep inside the superior frontal gyrus, SLF2 deep inside the middle frontal gyrus, and SLF3 deep inside the inferior frontal gyrus. And they will connect, you can see here, to parietal components. And we can see nice dissections of the literature from Dr. Khan, Yagrumoglu, of these tracts. And the most deep ones are, in fact, the arcade fascicle. And the arcade fascicle can also be traced using tratography. So these are nice images that we see on the literature correlating fiber dissection with tratography and how they come really close together. And this is an image from Professor Hugh Dufault trying to understand the functional role of each part. So the SLF is mainly seen as on the dominant hemisphere as an articulatory and phonological stream of language. On the right side, it would be more about visual cognition. So we have these 2 functional roles of the SLF. What about the frontal Aslan tract? The frontal Aslan tract is a tract usually seen on DTI and hardly seen on dissection, but it is connecting the inferior frontal gyrus to the superior frontal gyrus or SMA region. It's also an association fibers, and the literature has been related to working memory deficiencies or construction paralysis or visual spatial, where for us that are neurosurgeons, it has not been related to functional deficits when we work deep inside these tracts. Now, even more deep inside the frontal lobes, we'll have other tracts, but these all other tracts are really intermingled together. And to understand them, it's usually easily beginning at the insular lobe, because at the central lobe, deep inside the insula, since we have the basal ganglia is dividing these tracts into capsules. And if we follow this capsule superiorly, they will go inside the frontal lobe. But at the central core, what is nice that nature already separated them by this basal ganglia. But at the frontal lobe, they are really together. So let's scratch the insula here. We first decorticate. We see the extreme capsule. The extreme capsule of the insula is the first subicortical layer of the insula. It's made also by short association fibers, and these short association fibers are coming from the insula to the inferior frontal gyrus as well. So we can see here they are going to the superior opercula as well. If you go more deeply inside the insula, we'll have the claustrum, and then at this depth of dissection, we can see three sets of fibers, three fiber tracts. The more anterior one is the uncinate fascicle, then the intermediary one is the inferior frontal occipital fascicle, and the most posterior one is arising from the claustrum. It's called claustrofugal or claustrocortical fibers. This is a nice drawing of David Pease showing these three tracts that is deaf and how they will go into the frontal lobe. The uncinate fascicle will go from the temporal lobe to the frontal orbital region. The inferior frontal occipital fascicle will spread towards the frontal lobe and will connect these regions to the posterior temporal and occipital lobe. And both together form a semantic stream of language. It has been related to the semantics aspects of language by several authors doing awake craniotomies. And this is a picture from Dr. Dufault, also using these connections to explain this semantic stream of language. More posteriorly, we saw the claustrum. The claustrum spreads itself, spreads its connection towards all cerebral hemisphere, and it's hard to understand what it's made for, but unilateral damage of claustrum will not lead to functional deficit. So what is important for us neurosurgeons is that the claustrum can be approached or damaged without a functional problem if you do it unilaterally. What about the internal capsule? The internal capsule will be made by a lot of projection fibers inside the central core. It's really well seen, but then inside the frontal lobe, they are really merged. The most posterior and eloquent part of the internal capsule is made by the pyramidal tract that's coming from the pre-central gyrus. This is the most eloquent part of the internal capsule. It's related to the genu and to the posterior limb of the internal capsule. These are projection fibers. We have all other projection fibers. I'm just going to distinguish two. We have the fiber that's coming from the cortex to the basal ganglia, then thalamus, then cortex again. This makes a series of loops inside the frontal lobe. You can see these on the literature, each one related to a different aspect of cognition. We have a motor loop, an oculomotor loop, and a prefrontal loop, but it's really not related to functional deficits. When we work unilaterally, we can do this without being afraid of harming them. And another set of projection fibers is the cortical pontine cerebellar fibers. They will arise from all the cerebral cortex, but the frontal ones are distinguished as the frontal pontine cerebellar fibers. Of course, they will arise from the frontal lobe, going down into the internal capsule, and then more inferiorly into the pons, where these fibers will cross to the other side and get inside the cerebellum through the middle cerebellar peduncle. These are rising from all cerebral lobe. And more at the midline, we have the corpus callosum, and the corpus callosum and midline is a very compact structure with a lot of fibers, but laterally it will spread its fibers into all cerebral hemisphere, and the most anterior fibers are related to the frontal lobe. What is about the neurosurgical application of this is that the surface anatomy of the frontal lobe is hardly seen into surgery because we have these vessels and the pia mater and arachnoid over the surface. What is make us hardly see the suicide. So we use anatomy and technology to guide us. A lot of people will have ultrasound, intraoperative imaging, but some people of the world will not. Here in Brazil, unfortunately, we don't have neuronavigation on all our ORs. So we developed, we as our group, led by Dr. Guilherme Ribas, developed this set of craniocerebral key points that will aid us to understand where the main suci are. So you can see these on the literature. There's a set of landmarks that will correlate cranial surface to the cerebral surface, and each point will also be related to the deep aspect of these points as well. To the frontal lobe, we distinguish more 2 points here. This is the Stefano and the anterior squamous point, and the superior squamous point. So we can see the squamous suture here, what's more anteriorly and what's more superiorly. They will be related respectively to the anterior Steven point and to the inferior Hollandic point. So if you just take the superior aspect of the squamous suture, we can see that directly underneath this point, we'll have the inferior aspect of the central sulcus. That's the inferior Hollandic point. So this is the posterior margin of the frontal lobe. And if we see superiorly, what is the superior aspect of the central sulcus? The superior aspect of the central sulcus will be called the superior Hollandic point, and it will be 5 centimeters posterior to the bregma. So if we just use these 2 points, we can understand where the central sulcus is. And of course, the frontal lobe will be directly superior. Another interesting point is this point here. There's 3 centimeters of midline and 1.5 centimeters posterior to the coronal suture. This is the point that marks the connection of the superior frontal sulcus with the precentral sulcus. And this is an important part because we can use the superior frontal sulcus as a route to reach the lateral ventricle, as I'm going to show. If you have a superficial lesion, it's more easily. You can approach this superficial lesion directly, but of course, remember the white matter fascicles that are related to it. So if you have a lesion centered in the superior frontal gyrus, understand that if it spreads posteriorly, it will get inside the supplementary motor area, and if it goes even more posteriorly, it will get into the M1, the primary motor area. This is, of course, important if you are doing awake neurosurgery and you want to stimulate. You need to understand what function you are dealing with, so you can know what to expect that the patient will be transient. They will have a transient deficit. Of course, if you stimulate posteriorly, he can have a moderate deficit. If you stimulate more inferiorly, for example, the ventral premotor area, the patient is likely to have a speech arrest. So it's important for to understand which fascicles are you being connected to. And the more inferior you go, the more into language areas you are getting into. Of course, the inferior frontal gyrus will harbor the speech area, the expression area of language. And as most posterior you go, the more you get inside this area. Central lesions are always challenging. You have to know that anterior to them, you have the pyramidal tract, and posterior to them, you have some sensory areas, and you have to do some brain mapping not to harm these very eloquent fibers. Then deep inside the frontal lobe, we have the ventricle, and how to reach the ventricle, we have many ways. We have the interhemispheric way of doing this. This is the transcallosal approach. We have, of course, the transsulci approaches or the transfrontal approaches to the lateral ventricle. So this is the interhemispheric approach. It's more suitable for very midline lesions. So if you have an anterior horn and body of the ventricle, these are midline compartments. The first step is to go really close to midline, not harming the sinus. You have to work between these veins, okay? And it's likely to have a big space anterior to the coronal suture. But you have to work between these veins and then get inside this cleft between the falx on the midline and the medial surface of the brain. Laterally, the superior callosal cistern will have a cistern directly superior to the corpus callosum. Then underneath these main arteries, the callosal marginal inside the cingulate sulcus, and the pericallosal artery directly over the corpus callosum. And we will spread those arteries and look for the corpus callosum to do the callosotomy. Where we're going to do the callosotomy, of course, depends where your lesion is. If you want to get inside the third ventricle later, you need to understand where the foramen Monro will project on the corpus callosum. This is usually 2.5 centimeters posteriorly. So some people will do this callosotomy 2.5 centimeters posteriorly. Another interesting point here is to see the bregma and know that 5 centimeters posterior to the bregma will have the approach of the central sulcus into the interhemispheric fissure. Why it is important? Because you don't want to put your spatula over the paracentral lobule. If you put your spatula over the paracentral lobule, the patient is likely to have inferior limb motor impairment. So you put your spatula more anterior to this. Here we are going to do the callosotomy. The callosotomy 2.5 centimeters posterior to the genu. If we want to see the foramen Monro on the middle of our callosotomy, this is more anatomy view. No one will do a callosotomy this big, but it's just to pinpoint that inside the ventricle, you will look for some veins to guide us. The anterior septal vein directly over the septum, and the thalamus striate vein between the thalamus and the caudate nucleus laterally. If you want to go inside the third ventricle later, you will open the choroidal fissure and get inside the third ventricle to the roof of the third ventricle. If you want to go transfrontal, I am more likely to use the sulci. Some people will use the gyri, but the sulci are always pointing to the nearest ventricular cavity. So it's very nice to use the sulci to get inside the frontal horn. It's more suitable for lateral lesions because you're coming a little bit off midline. And so if you have a lesion on the caudate nucleus, perhaps using the superior frontal sulcus will be a nice approach. And we have this point that I said is 2 centimeters or 1.5 centimeters posterior to the coronal suture and 3 centimeters off midline. You will see this point that marks the posterior point of the superior frontal sulcus. So if you just understand this point, you can dissect the superior frontal sulcus from this point anteriorly and use this as a route to get inside the lateral ventricle. This is a very unusual approach to the lateral ventricle. This is a transinsular approach. If you are exposing the insula, you are spreading the opercula, you can use a very anterior approach to the anterior horn. I've never seen someone doing it, but it has been referenced on the literature. You will make a cut deep anterior to the insula. This cut will be at the anterior limiting sulcus and will approach the anterior part of the lateral ventricle. Okay, this is just images where we will make this cut to get inside the anterior horn. Approach to the lateral ventricle is an extension of the approach of the lateral ventricle, just to understand that you can go really transforaminal approach, or you can really open the choroidal fissure, what is called the transchoroidal approach. You can do the transchoroidal approach between the fornix and the plexus, the choroid plexus, or you can do this between the choroid plexus and the thalamus. You can choose. Most people will do it between the fornix and the choroid plexus, because then you can go between both internal cerebral veins and get inside the third ventricle. So these are just anatomy pictures. Here I am displacing here the fornix here and the choroid plexus here, and we'll make a cut between both these structures and displace even more medially the fornix to expose the both internal cerebral veins at the roof of the third ventricle, and then we can displace them and get inside the third ventricle. This is the transchoroidal approach. And in some cases, we can cut the massa intermedia and expose all the roof of the third ventricle. Okay, This is the subchoroidal approach. Some people will look for this route here between the choroid plexus and the thalamus. What is the disadvantage of this approach? You are coming from more laterally, and usually you will have the thalamus right vein anteriorly, what will block your view to the most anterior part of the third ventricle. So if you want to get into the anterior part of the third ventricle, it will be hard because this approach is will have the thalamus right vein on your surgical route. And I've never seen this also, but it has been referenced by Michael Apuzzo, the interfornicio approach. So you can go into both laminas of the septum pellucidum. Deep inside, you see both fornices, and between them, you will reach the roof of the third ventricle as well. Okay, this is a very clear approach, but unfortunately, I've never seen someone doing it. Okay, once again, thank you for the invitation. It's an honor to participate. Thank you.
Thanks a lot, Professor Vivas, for this excellent illustrative presentation. Thanks to you, Father Professor Villarno, and his revolutionary paper. We are now owed to you and him in every surgery that we all do because of surgical points. There is one question in chat box asking about disconnection syndrome when you're using anterior interhemispheric transcallosal approach.
Let me see. Is the Q&A how to avoid connection? Is the fornix important? I would say the fornix is more important than the corpus callosum, especially if you harm both fornices. The limbic system, it's a two-sided system. We have one limbic system on each side. You can harm one of the limbic system. You can take off one amygdala. You can remove one hippocampus. You can harm one fornix without having a lot of psychological problems, neuropsychological problems with this. But you cannot harm both fornices, and that's why the interforniceal approach, I would be a little bit afraid of doing it because you cannot harm both. About the anterior transcallosal approach, it usually does not have major functional deficits. We do this regularly, these small callosotomies, as I said, 2.5 centimeter posterior to the genu. We do like a 2 or 3 centimeter callosotomy. And on our experience, we have not seen disconnection syndromes, I mean, major functional deficits.
Thank you. Is there any other question from panelists?
Thank you.
Okay,
well,
yes.
Thank you
Thank
to be
you, Dr.
part
Vivas.
of this group.
Thank you. And now we will shift to next speaker, Professor Abida Shah. Please start sharing your screen.
Can you see it now?
Yes, it's
Yes.
okay.
Okay, can you hear me?
Yeah.
Loud and clear.
Okay. First of all, thank you, Samay, for again involving me in your great webinars. And today we are discussing frontal approaches. And so I would like to start with the basic anatomy of the anterior cranial fossa, which we have not yet seen in any of the presentations. So let's see the bony anatomy first. So basically the anterior cranial base is made up of a medial part and a lateral part. So the medial part has the crista galli, has the cribriform plate, and has the sphenoid. And the lateral part is the orbital part of the frontal bone and the lesser wing of the sphenoid. So to understand the approaches to the anterior cranial base, it is essential to understand this anatomy and how the approach varies with the lesion present in this aspect of the anatomy. So this is an image from the back, which shows the crista galli, the cribriform plate. You can see multiple holes in the cribriform plate, which allow the filaments of the olfactory nerves to pass. It also allows the anterior and the posterior ethmoidal arteries to go through. This crista galli and the anterior part has an attachment to the falx. And the a part of the sagittal sinus which goes into the nasal cavity may be present here. So when dividing it, you have to be careful. This is the sphenoid bone. As you can see, this is the body, the lesser wing and the greater wing of the sphenoid. The sphenoid the bone looks like it is shaped like a bat. Looking at the sphenoid from the superior perspective, there's the planum sphenoidale, the tuberculum sellae, the dorsum sellae, the chiasmatic sulcus. This is the grooves for the optic canal. This is the anterior clinoid process. This is the superior orbital fissure that is formed between the lesser and the greater wings of sphenoid. So the anterior cranial base, the approach to the anterior cranial base depends on where the lesion lies. So if the lesion lies in the midline, the approach is different. If the lesion lies slightly lateral, the approach is different. So in the midline, you see these structures, the olfactory bulb, the olfactory nerve, the olfactory tract, the optic nerves, the circle of Willis in this region, the anterior clinoid process laterally, and this is the orbital roof. So for midline lesions, a lot of people are now advocating the endoscopic approach. And this is the view that you get from the endoscopic approach of the suprasellar component and the olfactory region, and of course of the optic nerve and the pituitary. A lot of people also use the bifrontal approach, the bifrontal interhemispheric or the extended bifrontal approaches to approach lesions in the midline, as we saw Professor Sebehi using it. But this is a cumbersome approach. It involves a large craniotomy and it has an effect with olfaction. These are images from Professor Goel's book, and you can see that we have also used this approach previously for large lesions involving the anterior cranial base, and also basically for lesions that were going down into the skull base, like malignancies of the anterior cranial base and olfactory esthesioneuroblastoma that involve both the anterior cranial base and the paranasal sinuses. For that, this is a good approach. So you can see the extent of craniotomy and the extent of the bone work that is done. Also, while doing this approach, you have to remember that you can raise this beautiful flap of pericranium, that is the extended subgaleal flap, which is described by Professor Goel. And this gives a very good flap for reconstruction of the anterior cranial base and separating the extracranial from the intracranial cavities. So this is the extended subgaleal fascia pericranial temporalis flap. So this is just the images showing the craniotomy for a bifrontal approach. This is a two-stage bifrontal approach where first the frontal craniotomy is performed and then this piece of bone is removed that gives access to the lower part of the anterior cranial base. These are the frontal sinuses which you have to exteriorize if you're using this approach and if you have opened the frontal sinuses. This is with that bone removed and you can see the access into the nasal cavity. And this is an approach that sometimes people use for large craniopharyngiomas. We don't use it, but it is a part of the frontal approaches. So it is a bifrontal interhemispheric approach, and this is the view that it provides. You can see that both the optic chiasms, you can see the pituitary stalk, this is the olfactory nerves, and this is the corpus callosum and the region of the pericallosal arteries. But as you can see that the approach is cumbersome. The other approaches, so we've done endoscopic, we've done a bifrontal approach, then there is an anterolateral approach to the anterior cranial base, and that is the classic pterional craniotomy. I've already discussed this earlier. And this is the trajectory that you will find when doing a pterional craniotomy. You get access into the lateral part of the anterior skull base and back into the region of the basilar apex and the brainstem. Still, the midline access is a bit limited. So when you do a pterional approach, the access will be into the sylvian cistern, into the carotid cistern, and then backwards into the interpeduncular cistern using this trajectory. This approach to this part and the contralateral side through a pterional route is restricted. So now we come to this approach, the unilateral subfrontal approach, which is the topic for today's webinar. So you see, this is the bony anatomy, and this is the classic way that a unifrontal subfrontal craniotomy is performed. You can vary the size of the craniotomy going more medial or more lateral depending on the lesion. So this is the anatomy that is provided by this approach. So you see the frontal lobe is retracted, both the optic nerves are into view. This is the region of the lamina terminalis. This is the A1 on this side, the A1 on the contralateral side. This is the ACOM. This is the diencephalic leaf of the liliquist membrane. And now you can see the structures more clearly. This is the pituitary stalk, the ICA, the ipsilateral A1, the contralateral A1, the ACOM, the contralateral MCA, This is the optic canal and covered by the falciform ligament. So this approach provides you access to these three cisterns, basically the carotid cistern, the sylvian cistern, the lamina terminalis cistern, and the chiasmatic cistern. If you open the diencephalic leaf of the liliquous membrane, you have access to the interpeduncular cistern, as you can see in this image. So now the optic nerve has been elevated here. You can see some arachnoid trabeculations here. This is the carotid cistern, the opticocarotid space. And when you enter into this region, you will get access to the interpeduncular cistern. As you can see here, this is the basilar artery. This is the posterior clinoid process. This is the third nerve. This is the anterior clinoid process. And here the ICA has been retracted medially. This is the optic nerve. So you see with this subfrontal approach, the angle of view, the way you can reach to this region is very abundantly clear. This is a close-up view showing the posterior aspect of the exposure using a subfrontal approach. So now this is the anatomy that we can view from a subfrontal approach, and it provides a very versatile approach to the anterior cranial base. Going posteriorly, this is the third nerve, this is the basilar artery, the basilar bifurcation. This is the optic nerve on ipsilateral side, contralateral side. This is the contralateral carotid artery. And you can see that the entire midline of the anterior cranial base can be easily exposed by this subfrontal route. So going to the technique, as I showed you earlier, this is the basic craniotomy. The burr hole is formed here, just beneath the superior temporal line in the region of the key burr hole. The position of the patient is, of course, supine, and the head is extended and turned to the opposite side. And this is the flap that is raised. The skin incision might be a hairline skin incision, or sometimes if there is no hair here, you can use a skin crease incision based on the forehead crease lines. So this is the incision. This is, as I discussed earlier in the pterional approach, you go subpericranial, you lift the pericranial here in the region of the superior temporal line. Also, you take the superior temporal fascia along with it. This prevents injury to the frontalis branch of the facial nerve. So here you can see the exposure. This is the superior temporal line in the muscle. So unlike a pterional craniotomy, you do not need to dissect the whole muscle here. And that also avoids the problem of temporalis muscle atrophy. So all you need to do is just push this muscle down in this region till you get an exposure to the key burr hole, and you can then perform the craniotomy. So this is the typical size of the craniotomy. So the craniotomy has to be about a 1 to 1.5 centimeter above the superior orbital rim. And as soon as you lift the dura, you will get access to the anterior cranial base. This structure that you see here is the orbital roof. So now just to show a few steps of the subfrontal approach, this is a patient with a suprasellar epidermoid. And this is just a small edited video, which I will show you so that you can understand the basic steps. So here you see, this is Professor Goyal operating in a workshop on a suprasellar epidermoid. So the dura has been opened. You can see the size of the craniotomy. This is the burr hole. The burr hole comes easily beneath the muscle and will not be visualized. So the first step in this approach is to open the go laterally and to open the sylvian cistern. And you can see that the CSF is released and the brain becomes lax. Then you start retracting the frontal brain off the anterior cranial base floor. And you start seeing the tuberculum sellae. And after you remove some more arachnoid, you will start seeing the tumor. This structure here is the olfactory tract. So using this approach, you can preserve the olfaction of the patient very well. So going further, now you can see the tumor. First thing is you identify and preserve the optic nerve. You see how the optic nerve is straddled within the tumor. It has actually become a thin membrane here. This is the epidermoid tumor. And now the tumor will be entered. Sorry. So the tumor removal is begun. And as the tumor is being removed, the first structure that you will see here that red thing that will come into picture is the pituitary stalk. So direct midline exposure to the pituitary stalk and both the optic nerves. Here you can see it more beautifully now. You see how the tumor has practically engulfed all the neurovascular structures. This is the pituitary stalk here. Once you remove the tumor from this side, you will see the third nerve. Here, this is the third nerve here. This is the liliquist membrane. You can see the arachnoid here in this region. Now coming to the ipsilateral side, you can see how thinned out the optic nerve is, and just a tumor removal is being done now. So this small approach gives you a beautiful access to practically the whole anterior cranial base, and it gives you access right up to the interpeduncular cistern and up to the basilar artery, and to both the sides, to the optic nerve on this side, the optic nerve on the other side, the carotids on both the sides. So it is quite a versatile and beautiful approach. Now just coming to the end of this video where you can see the anatomy. So the ipsilateral, just a minute. So the ipsilateral optic nerve, the contralateral optic nerve, here's the pituitary stalk. This is the third nerve. This is the PCOM. This is the carotid artery on this side. This is the carotid cistern on this side. So you can see all these structures beautifully with this approach. Again, olfactory groove meningiomas. This is our experience with 129 cases. Earlier, we used to use a bifrontal approach. Now we use only a unilateral subfrontal approach. And this tumor I have removed, and you can see the post-op images. We also use this approach for tuberculum cellae meningiomas. You can see this is the midline lesion approached by a unilateral subfrontal approach. We use it for craniopharyngiomas. We use it for hypothalamic gliomas, for optic nerve gliomas, for lesions in the anterior part of the third ventricle, as you can always go and open the lamina terminalis. Now, what about this lesion? Now, how do we approach this lesion? Dr. Ribas just had a beautiful presentation showing us approaches to the lateral ventricle. But this is an area of the lateral ventricle that is a little below. It is in the inferior part of the frontal horn. This is actually a lesion of the caudate. And we described an approach using the subfrontal approach to lesions in the inferior part of the frontal horn or lesions to the caudate, lesions in the caudate head. So this is the trajectory. Of course, the craniotomy will be the same in this region. And this is the trajectory. The frontal lobe gets retracted by your head extension. And this was the paper that we've described, the orbital cortical approach to lesions around the frontal horn of the lateral ventricle. And more further, we did the white fiber dissection of this region to realize what are the fiber tracks that come in the way and which can be preserved while doing this approach. So as Dr. Ribas had described, you can use the ipsilateral interhemispheric approach to the frontal horn. You can use the contralateral interhemispheric approach to the frontal horn. You can use a transcortical approach to the frontal horn, but you see how long these trajectories are. You can see how long all of these trajectories are. And this is the caudate head in the body of the lateral ventricle. So once we measured these distances of the caudate head, and we found that it was closest to the surface when you used a medial orbital approach and then a lateral orbital approach. And I will show you the anatomy of this approach. So he was describing this H-shaped cruciform sulcus of Rolando, which is clearly seen in this specimen. And this is the medial orbital gyri, the anterior orbital gyri, the posterior orbital gyri, and the lateral orbital gyri. And this is a basal part more of the frontal lobe where you see the anterior perforated substance. You see the lateral and the middle olfactory striae. And I'm showing this because deeper dissection in this region will show you some beautiful white fibers. So this is the approach that we've described to the inferior aspect of the frontal horn and to caudate head. And true trajectories we have used, the medial orbital trajectory and the lateral orbital trajectory. These are the entry points. So basically the medial orbital entry point is in line with the temporal brain at the temporal tip, and you just enter it, and the trajectory is in this direction towards the frontal horn. When you're going from the lateral, this is the direction of your approach, and you reach the caudate head. Now, while using these lesions, while using these trajectories, there are certain fiber tracks that will completely be avoided. So it is basically safe and there is no injury to the white fibers when you're using this approach. Again, you see this is the frontal horn, this is the caudate head. These are the two trajectories that we use to approach this lesion. So deeper dissection in the region of the frontal horn and on the base of the frontal brain, you see these fibers. So this fiber that you see here is the beginning of the anterior commissure. This is the substantia innominata. These fibers that are running are the uncinate, are the dorsal component, the ventral component of the uncinate fasciculus, which connects the base of the frontal bone to the olfactory region and to the amygdala in the temporal brain. So these are uncinate fibers. This is the genu of the corpus callosum. This is an upturned image. Going deeper, now you see the anterior commissure more beautifully. This is the gray matter of the substantia innomata. This is the diagonal band of Broca. This is the frontal horn. These are the fibers of the uncinate. So when you're approaching the frontal horn, you basically, just imagine this is an upturned image. This is the frontal brain, this is the temporal brain, this is the corpus callosum, and this is the frontal horn. So when you enter from a medial approach, the only fibers that might get transected are the fibers of the forceps minor. No other white fiber bundle will come in the way. And when you're coming from a lateral approach, you have to avoid the fibers of the IFOF that can run just beneath your trajectory, and you enter into the frontal horn using this approach. The uncinate fibers are more posteriorly and will not get damaged when you're using this approach. So this is white fiber dissection done at the base of the brain, and you can see these corpus callosum fibers beautifully. This is the genu and the rostrum of the corpus callosum, and you see how they are connected to each other. Some fibers of the rostrum of the corpus callosum go on to join the fibers in the temporal stem and in the basal ganglia. This is the region of the insula, and you see how close they run to the IFOF. And here, this is the region of the substantia innominata and some parts of the uncinate fasciculus that come here. So you see how safe this approach is based on the white fibers, because the white fibers are quite deep in this region. This is just the lateral view showing the fibers. So this is the IFOF, this is the uncinate fasciculus, this is the frontal and the temporal brain, and this is the region of the extreme capsule. When you lift this, you will have the dorsal external capsule. And just to complete the anterior commissure, you see this, the anterior commissure has two components, the anterior and the posterior part, and the posterior part goes all over and joins the sagittal stratum, and it is as if the anterior commissure is hugging both the temporal horns, and it encompasses it on both the sides completely. And this is the anterior component of the anterior commissure, which connects both the olfactory regions to each other, and this is the gray matter of the substantia innominata. So the frontal horn comes in this region, and none of these fibers will get damaged. This is just an image showing how the anterior commissure forms part of the sagittal stratum. So this approach, as you can see, this is the ventricle, this is the caudate head, and these are the fibers of the corpus callosum. So using this approach avoids all these fiber bundles. And we have done many lesions using this approach. So this was a patient who presented with intraventricular hemorrhage. And you can see the image showing a AVM in the inferior part of the frontal horn, which we removed using this orbital approach. So this is a classic indication for this approach. This is a lesion of the caudate head, and you can approach it coming from a lateral orbital trajectory. These are the white fiber DTI construction showing the tumor on this aspect of the fibers, and you can enter, you can see this trajectory, the lateral orbital trajectory to enter the caudate head, and you can see how beautifully the tumor can be removed. This is again another lesion in the region of the caudate head, and operated using this lateral orbital trajectory. So these are a lot of cases that we have done using this approach, and we found it to be very safe and without causing any problem, and with a very good working angle with a short distance and not causing any problem. So this is basically the anatomy of the subfrontal approach, and you can see how versatile it is and how much of the anterior cranial base can be approached using this subfrontal technique. Thank you very much.
Thank you, Professor Abida, for this illustrative, excellent presentation. Is there any question from panelists?
Very nice presentation, Dr. Abina Shah. Congratulations.
Thank you, Dr. Ribas.
Okay, we will shift to next speaker, Professor Atul Goel.
Yes, Dr. Sameh, I'm here. Just let
The king is here.
John, So I have
I
been
told-
actually, I'm traveling and I'm not in my home to give you, I hope my presentations work. So let me see.
Okay,
Okay.
So you can see my presentation?
yes.
Yes, okay.
Okay. So what I'm going to talk today is on my personal opinion about when to use a nasal approach and when to use a cranial approach. As we all know, endoscope is a very popular instrument these days. And of course, we have to learn endoscopic surgery. And I will encourage all young neurosurgeons to learn endoscope. But whether we are overusing endoscope and whether we are not using our cranial approaches, which we have developed over so many years, that is the subject of my discussion today. My opinion on when to use cranial and when to use nasal route. When I talk of nasal, I mean whether you want to use microscope or endoscope, that is immaterial, nasal or cranial. So you see, the whole brain is surrounded by a very firm and very resilient membrane called dura or dura mater. Mater means mother, mother dura. So the dura covers the brain and it forms a very strong partition or compartmentalization between the head and subhead regions, subcranial regions. So this dura is absolutely a magical material. And there are no holes in the dura. When there is a nerve, the dura goes along with the nerve. When there is an artery, the dura goes along with the artery. So there is no hole as such. And this dura has to be preserved and has to be respected because the tumors respect the dura. And you see, this is the sella and how beautiful is the sellar floor and the anterior clinoid processes and posterior clinoid processes. What I have to say is the dura comes first, the bone comes later. Dura is stronger embryologically and dura is stronger morphologically than bone. So bone is not as strong as dura. So the tumors can destroy the bone, but may not be able to destroy the dura. So this is a very important for a neurosurgeon who is going to operate on these lesions. So this is the dura of the diaphragm celli. This is the pituitary gland, and this is the pituitary stalk. There is a hole. This hole is not exactly a hole in the dura because dura continues. Dura does not stop. Dura is like a sheet of bed sheet. It is folded. It does not stop. And if you see the membranes from underneath, from the nasal root, you see these membranes are like mucosal membranes, and these are not as thick or as strong as the dura. So that is why cavernous sinus is an extradural structure. Both carotid arteries are actually extradural. So this controversy, whether it is dura or whether it is extradural, has remained for a very long time, whether cavernous sinus is extradural or intradural. But basically the premise is that dura is, you see, if you see this, there is dura above the cavernous sinus. This is dura, and the basal part is not exactly dura. The dura turns and dura forms the border of the sella. And this cavernous sinus is extradural. So to have this kind of anatomy is quite a beautiful, this is a cadaveric specimen, and we should never see such an anatomy during surgery, because if you see such an anatomy during surgery, you are certainly not going to be able to repair the dura and make it watertight. And this patient cannot survive, in my estimation. So you never, this is a cadaveric specimen. Pituitary gland has a special location. It is neither intracranial nor extracranial. It has its own special compartment. Cavernous sinus has a special compartment, special relationship with the pituitary gland, special relationship with the paranasal sinuses, special relationship with the carotid artery, very special relationship with the cranial nerves, which all have their own dura. This dural cover with, there is a dural cover with every cranial nerve. So this understanding of dura forms a very important understanding for our surgery. So there are several articles written by me about skull-base reconstruction, and I wish that you read some of these articles, because when we operate either by transcranial route or by nasal route, reconstruction becomes very important. Reconstruction, if we are operating from a cranial route, reconstruction is much easier than when we are operating from a nasal route. And the membranes, the various layers of the fascia, superficial temporalis fascia, deep temporal fascia, subgaleal fascia. You see, we had described this special layer called subgaleal fascia. And we can, subgaleal means when we talk of galea, we talk of subgalea, we always talk of fat. But there is a distinct layer called subgaleal fascia, which can be used for reconstruction. And it is very highly important that we use a vascularized pedicle reconstruction when we do a reconstruction either from the head or from the nose. So I have described several vascularized pedicle flap. This is muscle fascia flap. You see the superficial layer of temporalis fascia is everted and a long facial flap, extended temporalis muscle fascia flap, multi-layer flap, vascularized osteomyoplastic flap, extended subgaleal fascia, pericranial flap, multiple layer facial construction of the middle fossa, and things like that. We have also described the use of outer layer of dura as a pedicle flap. So essentially what I'm trying to say is dura is an absolute waterproof covering of the brain. And if we are going to operate from the head or from the nose, this waterproof reconstruction of the dura is absolutely critical. Reconstruction of dura from the head is much more simpler, much more safer than reconstruction of dura from the nose. We have also discussed the use of mucosa, that is involving the sphenoid sinus for reconstruction, and reconstruction using cellular flow mucosa as a vascularized flap. Many of you have heard me on several occasions talking about membranes, and membranes are mother, and membranes are, meninges are the mother of brain. And this is what we have derived from Arabic legacy. Alam al-Dimag means meninges are the mother of brain. Meninges come first, bones come later. Meninges come first, brain comes later. So meninges are absolutely primitive embryological formation, which the tumors respect. Dura is durable, and about dura, we have written several articles which you will like to read. So when we are operating, we should not become expert in endoscope and we should say that every tumor can be removed from endoscope. That is an absolutely dangerous kind of philosophy. There are some tumors which we should remove by endoscope or by nasal route. Some tumors we should remove only by cranial route. And it is absolutely not correct to say that I can do from nasal route all these kind of tumors. And that I am going to discuss as to what my policy is when I will like to use nasal and when I will like to use cranial route. Long time ago, I had written about how the carotid artery is encased and how it is displaced. And this displacement or encasement will decide what kind of surgical approach you will take. This is my paper which I have written about 25 years ago. First, I will like to talk on pituitary tumors. Pituitary tumors, many of you are young neurosurgeons or young residents. This kind of pituitary tumor, about 25 years ago, everybody wanted to remove these tumors by transcranial route. Everybody used to do transcranial route. Nobody would even venture transnasal route. For the first time in the literature, we made a very important contribution in this subject, that dura of the diaphragm celli is elevated on the dome of the tumor. So this tumor is encased. Here is also dura. So this is completely an interdural tumor. There is no artery of circle of Willis inside the tumor. So this elevation of diaphragm celli is an absolute fantastic observation that we made 25 years ago. So grade 1 tumor is pituitary, where the diaphragm is elevated on the dome of the tumor. Prior to our discussion, what the whole world used to say is that the rent of dura for the stalk, this part of the tumor is subarachnoid and this part is subdural. So this description that the entire thing is within the dura allows us to do a nasal operation. So whether we use endoscope or whether we use microscope, that is not very critical. But this fact that if the dura is elevated, you remove the tumor, the dura will come into picture. So dural elevation, you can see clearly the dura is elevated on the dome of the tumor. So this information was not there 25 years ago. Even when you see this kind of nubbin, it is under the dura. If you see this kind of nubbin, it is under the dura. So the whole tumor is interdural or within the confines of the dura. If you do not have this understanding of dura, you come from transcranial or you come from transnasal, you will certainly most likely damage the person. So this kind of, you see, this kind of nubbin is within the dura. So the whole thing is within the dura. So this understanding is very, very important. Grade 2 is when I call it grade 2, the tumor encases the internal carotid artery. The tumor enters into the confines of the cavernous sinus. And as I mentioned to you, this dura, you see the lateral wall of cavernous sinus dura is elevated on the dome of the tumor. This tumor does not transgress the lateral wall of the cavernous sinus. So this tumor under the diaphragm, under the lateral wall of cavernous sinus. Now, what area, how it transgresses the medial wall of cavernous sinus, whether it is interdural or whether it is extradural, it is a little bit of a controversial subject. But what happens is the whole tumor is under the diaphragm dura and under the lateral wall dura of the cavernous sinus. So there is a dural confinement. So no matter how big this tumor becomes, there is dura here, there is dura here, there is dura here. So understanding of the presence of dura will allow you to do a transnasal operation. So dura may be stretched, but dura is intact. You see the dura is stretched, but it is completely and entirely intact. Here you see, if you see this picture, there is entry of the tumor into the cavernous sinus. Here there is entry into cavernous sinus. and dural roof of cavernous sinus is elevated. Diaphragm is elevated. So this elevation of dural roof, it is very important to understand that this elevation of dural roof of cavernous sinus, if you have this understanding, you can remove it by the nasal route. So my understanding is majority of the tumors, pituitary tumors, should be removed by nasal route, and transcranial route is not a good option. So you see the dura of the roof of cavernous sinus, dura of diaphragm. Clearly you see the dural elevation, roof of cavernous sinus is elevated, the diaphragm is elevated, the roof of cavernous sinus, dura, diaphragm, roof of cavernous sinus. So there is a method in the aggression of these tumors. There is a method in the madness of these tumors. They have a confined kind of extension. Very rarely these tumors transgress the dura. And when they transgress and encase the arteries of circle of Willis, I like to call them aggressive tumors. And the surgical philosophy for these tumors is completely different from other types of tumors. So this gradation of mine about the dura, about the dural confinement is absolutely important. And I have no hesitation to say that the popularity of transnasal route for all these kind of tumors is because of the understanding of the dural membrane. You remove the tumor and the dura will fall into the picture. How you understand the walls of cavernous sinus, how the cranial nerves are displaced by the tumors have to be clearly understood. If one understands this concept, I think the surgery of pituitary tumor can be completely a nasal surgery and not a transcranial surgery, except for grade 4 pituitary tumors where the surgical options are of different kind. So this is the elevation. You only remove the anterior wall of the sella. There is no need to remove the planum sphenoidal or tuberculum celli. Remove the anterior wall, debulk the tumor, and within 10 or 15 minutes, the entire tumor, the diaphragm will be in picture, and there may not be any need to even do a skull-base reconstruction. There is no need to take any vascularized flap or anything if you preserve the dura. So transcranial route is a very important route. Like this fetus, the uterus is a very strong structure. It pushes the baby out. So these cesarean sections may be good, may not be good, but the understanding is that the dura is as strong as the uterine muscle. And the dura is as solid and consolidate structure. So this is, you take an incision in this cellar part, debulk the tumor. Many of these tumors are soft tumors. Many of these tumors may be vascular tumors, but the thing is debulk quickly. There's no need for coagulation. And within 10 or 15 minutes, you can remove this tumor completely and beautifully. So these tumors are essentially non-functional tumors. And once you remove the tumor, the vision comes back and you give a new life to the patient. This kind of subfrontal extension was a classical indication for transcranial approach, but understanding that the dura is intact, you can, and how to bring this part of tumor into the field has to be learned and has to be acquired. Even when the tumor goes right up to the corpus callosum, you just work in this area, and get the dura into picture. And if you realize I did this case 22 or 23 years ago, and at that time, 100% of time, this tumor would have been operated by transcranial route. But this understanding of the dura made me remove this tumor by a transnasal route. I did this operation 24 years ago, just taking incision and removing the whole of tumor, and this tumor beautifully removed by understanding of the dura. How the cavernous sinus portion of the tumor should be removed is absolutely another chapter, but understanding that the dura is intact, these tumors are soft, and these tumors which involve the cavernous sinus have to be removed transnasal surgical route. You see this part of the tumor, you can enter. About 21 years ago, I removed this tumor and I entered into the cavernous sinus, and this part of the tumor was removed. So understanding of the dura is an absolutely critical, and my opinion is firm that pituitary tumor should be removed, whether endoscope or microscope. I use only microscope, but endoscope is a good tool. This kind of tumors which encase the arteries is another chapter. So I've got several articles on pituitary tumors, and I wish you can read it. This is one tumor which is nasopharyngeal angiofibroma. Even when they become large, even when they become huge, they remain extracranial and extradural. They never enter into the confines of cavernous sinus. You can make a beautiful plane of dissection, and these tumors should be removed by a nasal route. There is no scope for removing these tumors by transcranial route. These are nasal operation. I had described in 1994 an extended transcranial route for these tumors, but today I am saying there is no way, unless it is extremely massive or unless it is going right in the infratemporal fossa and beyond, maybe transcranial route may be an option, but in general, nasopharyngeal angiofibromas should be removed by a nasal route or extended mid-facial degloving operation. Now I want to talk about meningiomas, and meningiomas is our life, meningioma is our subject, and meningioma is a very common lesion that we deal with. So in 2002, I described 70 cases. Now my experience is beyond 300 cases, which is the largest series in the world. Olfactory groove, this is the largest personal series in the world. So on the basis of my 40-year experience in neurosurgery, I will like to give you my opinion about tuberculum celli meningiomas and about olfactory groove meningiomas. And as you must have heard, that many people like to do tuberculum celli meningiomas, and even some people are nowadays describing olfactory groove meningiomas to be removed by a nasal route. I am telling you, my opinion is absolutely clear that there is no way, under no circumstance, you should remove these tumors by a nasal route, which is an absolutely dangerous surgical operation. So this is one meningioma. This is a little larger. This is a little bit more bigger. This is a little bit wider. This is little away from the sella. Now you see there is a opening here in the region of the sphenoid sinus, in the region of paranasal sinuses. And many people would like to do a transnasal route. I am saying under no circumstance you should do tuberculum celli meningioma by a nasal route. It is absolutely irrational and absolutely wrong operation. You will ask me why. I will like to explain to you. So this tumor is within the chiasma and the sella, can involve the carotid artery, can go lateral, can have a calcific rim. You see, these are various types of tuberculum celli meningioma. They encase the internal carotid artery and anterior cerebral artery complex. They may be very heavily calcified. They may have edema around them. So understanding of tuberculum celli meningioma is very important. Understanding the relationship of tuberculum celli meningioma with anterior cerebral artery is absolutely critical and crucial. If you have to attack a tiger, you have to attack up front. You cannot hold his tail and start pulling it. You will never be able to attack a lion like this. You have to understand the capabilities of the lion. And if you understand, these tumors may look like flower to you. So on the basis of various kinds of tuberculomas, we had made a gradation system of tuberculum meningioma on clinical parameters when they come with convulsion, when they come with visual deficit, when they come with severe visual deficit, moderate visual deficit, duration of deficit, and various other radiological like calcification, encasement of arteries, going into the sphenoid sinus, extensive edema, and things like that. We had made a classification of tuberculum meningioma in 2002. So 20 years ago, I had published this 70 case experience. So when you are going to operate on tuberculum meningiomas, the most critical and most important thing is anterior cerebral artery and its perforator. I have to tell you, with my experience of more than 300 cases, if you take one perforator of anterior cerebral artery, you can clearly damage the person. You can damage the person like absolutely you can create hemispheric deficits. So you come from front, you come from subfrontal, debulk the tumor, identify the optic nerve, debulk the tumor. At all times, you have to isolate the anterior cerebral artery and its perforator. Many a times they are very badly stuck to the dome of the tumor. If you come from the nose, this one perforator you damage, these which you will see at the end of the operation, and it may not be possible for you to control the bleeding. It may not be possible for you to repair the rent. It may not be possible to save the patient. So in my estimation, these operations, transcranial, are so simple and beautiful. Many of these operations can be done in 15 or 20 minutes, or half an hour is a very long operation. Come subfrontal, open the Sylvian fissure, relax the brain, identify the optic nerve, debulk the tumor, then identify the anterior cerebral artery, identify the perforators, protect the perforators, and go on debulking and resecting the tumor. So this is one beautiful tumor to operate by transcranial route. They are quick. They are never hugely vascular. They are, sometimes they can be firm and gritty in consistency. Never in my 300 cases I have ever damaged the pituitary stalk. The Lilliquist membrane is very strong. You don't have to go beyond the Lilliquist membrane, of course. And there is a beautiful arachnoid sheath which separates the pituitary stalk. And these tumors have to be debulked. Anterior cerebral artery has to be identified and separated. And these, even when there are calcified tumors, these kind of tumors, I will say, is an absolutely irrational and may not be a correct operation to do by the nose. And there is no question of having a CSF leakage when you are coming from the transcranial route. Debulk the tumor, learn the art of breaking the tumor, learn the art of demolishing the tumor without doing any major coagulation. So that is my opinion about tuberculum meningioma, that there is no way I will recommend even when it is seen. And I will not, people may have their opinion and they should have their opinion and they must have their opinion. But my opinion is absolutely clear for me that these tumors are cranial operations and you have to do by cranial route and not by nasal route. So we have done several of these cases over the years and we have enjoyed this operation. Even when they go lateral and anterior cerebral, then of course you have to go lateral. But basically my surgical strategy is subfrontal operation. Identify, I hope I can show you the video if possible, but I'm not sure. Maybe at the end of the operation, I will show you the video. So suprasellar meningiomas are difficult operations, but do not make them more difficult by doing them from the nose. So my opinion is that tuberculum meningiomas, olfactory group meningiomas are very fantastic cranial operations, and you should not do this kind of operation if you come from the nose and start using your endoscope and say, I am expert in endoscope, I can do anything from the nose. I think you can do anything, but don't do stupid thing from the nose. Come from front, do a smallish craniotomy, retract the brain, debulk the tumor, make the artery safe, make the cranial nerve safe, and remove these tumors. So majority of these tumors nowadays we remove by only unifrontal approach. There's not even need for bifrontal approach. Most of the time is spent on breaking the tumor and not in the approach. So if you do any kind of nasal approach, I think it is an absolutely wrong, and I don't believe that this kind of nasal approach should be done. Even foramen magnum meningioma, I have seen some people recommending a nasal route. I will say under no circumstance I will do a nasal approach for a foramen magnum anteriorly placed meningioma. You do a smallish craniectomy, do a little bit of hemilaminectomy, have the vertebral artery under control, learn the art of breaking the tumor between the cranial nerves. So my opinion is absolutely clear. My opinion is absolutely firm for me. Doing nasal route surgery for foramen magnum is an absolutely unwarranted and unnecessary approach, and making a, running behind the mouse from a different direction is not such a great operation. So we have done all kinds of foramen magnum meningioma by a smallish route, by a posterior midline operation, midline posterior suboccipital, not even lateral, not even, there is no need for exposing and displacing mobilizing the vertebral artery. Even these kind of ossified tumors, I would like to show you some tumors. This is a meningioma in front of the brainstem. It is completely, you see on CT scan, it is completely ossified. I did a smallish craniectomy here, worked within the cranial nerves, learn the art of breaking all kinds of tumors, and you will be able to remove this tumor. This is another ossified tumor right in front of the brainstem. You see how the vertebral arteries are encased by the tumor. And if you say very good from the nose, I will remove the clivus and I will come from the nose, I will say absolutely rubbish kind of thing you are talking about. You break the tumor, protect the arteries, protect here, both the vertebral arteries are encased within this ossified tumor. So you have to, you have to protect the arteries, protect the nerves, and remove the tumor. This is another ossified tumor. You see how it is, and you can do by cranial route. So in general, for all meningiomas, foramen magnum meningiomas, tuberculum meningiomas, olfactory group meningiomas, my opinion is clear. My opinion is absolute. About craniopharyngioma, my opinion about craniopharyngioma is majority of craniopharyngiomas are very beautifully removable like a placenta. You hold the tumor and you can remove the tumor. But the issue is any problem with the arteries here on the dome of the tumor can be a big problem. If you come from the nose and you damage one artery here and there, it can be a difficult operation. So my opinion about craniopharyngioma is, it is a straightforward operation because there is a clear margin of dissection and you can remove this tumor even by the nose. But if you ask me, my opinion about craniopharyngioma is, when the sella is huge, you do a nasal route. When the sella is small, you do a cranial route. So this is sella is small, you don't come from the nose, you come from cranial, work interoptic or work from lamina terminalis and remove this tumor. So if I can show you this video, I'm not sure, but unfortunately my videos are not working. So meningiomas of various types. Important is learn how to remove a tumor. And my beauty with my surgical experience, I have worked in public hospital, charitable hospital, where many cases we have been able and fortunate to be able to operate. So this was in 1993, this was in 1995. So cavernous sinus has been my very important forte over the period. And most important is to understand the meningeal architecture of the cavernous sinus. So we had first described extradural approach to cavernous sinus, intracavernous sinus tumor for the first time in the literature, tumors. Of course, Vinko Dolenz had described vascular lesions, but this was tumors. So trigeminal neurinoma, which is, as many of you know, is my very favorite subject, we described that trigeminal neurinoma is within the dural confines or interdural in location. The carotid artery is displaced medially by the tumor, medially. And the nerves of the trigeminal nerve are displaced on the dome of the tumor. Carotid artery is displaced and the dura protects the carotid artery. Dura protects the third nerve and the fourth nerve, and the dura protects the sixth nerve. The sixth nerve is displaced medially by the tumor. So more recently, I have been watching some webinars and watching some opinions that many people are saying that I will remove trigeminal neurinoma from the nose or by endoscope. My opinion is absolutely clear. It is not necessary. It is dangerous to remove trigeminal neurinomas from the nose because the carotid artery is medial, the sixth nerve is medial, and also the cranial nerve fifth is in an uncertain position which you cannot. So you come from lateral. There is no need to come from medial. So in 1995, we described, about so many years ago, you can see that we described surgery on trigeminal neurinoma on the basis of interdural approach by just opening the Meckel's cave. So this is infratemporal lateral approach. Open widely the Meckel's cave and work within the dura, Don't go outside the dura, debulk the tumor, and then save the cranial nerve. So we remove this. Samay. So this tumor was that?
We got it.
Okay.
So when the tumor is even going to the posterior cranial fossa, we removed in 1994 this tumor by just opening the Meckel's cave. So understanding of the dura is absolutely critical. This type of tumor, many people nowadays are talking about transnasal route, but it is not a good option because the sixth nerve is uncertain, carotid artery is uncertain, and you come from lateral and remove this tumor. That is my opinion. So my opinion about trigeminal neurinoma of this kind is don't come from the nose. Come from lateral, open the dura, work interdurally, and you can remove these massive tumors beautifully in a very systematic and designed fashion. Trigeminal neurinomas, of course, for larger tumors, I have discussed about extended basal approaches. Now I do very smallish craniotomy and do by splitting of the temporalis muscle. This is my current, this kind of tumor. I just make a small craniotomy, understand the tumor, break the tumor, debulk the tumor, and then identify the cranial nerves and separate and save the tumor. And you have to improve the trigeminal sensation. This kind of improvement of the trigeminal function was first described by us about 25 years ago. Before that, nobody talked about improvement of the trigeminal function or improvement of the sensations of the face. So trigeminal neurinoma is a very fantastic skull-based operation. Don't make it nasal, make it cranial, work within the dura and understand the dural confinements. These, even when there is a nubbin, it is within the dura and you work in that direction. You see, this tumor can break the anterior columnar process. If you say, I will remove the anterior columnar process, not necessary. You will say, I will do petrosectomy, not necessary, because the tumor itself does. So when the tumor goes even extracranial, there is a dura, and that has to be understood. And if you understand this dural, these tumors may not be required to be done by nasal route. Make a small opening lateral and work within the dural membranes. So even when the tumor recurs, it remains within the dura. Now I want to talk of another tumor. This is cavernous hemangioma, and many of you have heard me talking on this tumor. These are the most vascular tumors, most benign tumors, and they are completely in the confines of cavernous sinus. And they have very characteristic radiological picture, goes up till the orbit, Meckel's cave towards the cavernous sinus, intercavernous sinus. They never touch the pituitary gland. So this location has to be understood. Now, this location is very close to paranasal sinuses. If you don't realize what tumor you are going to operate and you are coming from the nose, there can be a surgical disaster. Never do this operation by a nasal route. And those who are saying I can remove this tumor by a nasal route, maybe either very highly expert people, or they don't bother about the tumor that they are operating. My opinion is absolute. You understand these tumors, they have very characteristic radiological picture. They are heavily vascular tumors. If you go from the nose, you may not be able to control the bleeding. Very characteristic extension towards the sella, towards the Meckel's cave, towards the orbit, encasement of carotid artery. These tumors have to be removed by an extradural lateral approach, which we describe for the first time in the literature for these tumors. And my opinion is absolute, and there is no question that transcranial route, subdural is not a good option. Extradural route is a beautiful surgical for these difficult tumors. And if you want to see the anatomy of these tumors in a panoramic fashion, these are the tumors you will see cavernous sinus in a very fantastic manner. So we described our experience with 45 cases, which is the largest experience in this area. So this is one. Okay, this one, unfortunately, it is working. So I am working within the, you see, I have opened the extradural. It is an extradural operation. It is a vascular tumor. It will bleed, and you have to open it and then, wait. And then deep, there is no, you see how furiously it is bleeding. But and this is, this operation was done in 15 minutes. It is an unedited tape, actually. I have just gone a little bit ahead, and I'm showing you this bleeding. If you are ready to accept and control this bleeding, you can do this operation. And if you start this kind of extensive bleeding from the nose, you will create a panic situation in the theater. And you see there is an inferior lateral trunk of the carotid artery in the cavernous sinus, which is the principal supply of these tumors, which you have to coagulate. And to coagulate this from the nose may not be a possibility. So these cavernous, and you see how the bleeding is under control, and without much coagulation, you remove the tumor. Sometimes the tumor is supplied by McConnell's capsular artery and sometimes by meningeal artery. But basically, you have to remove these tumors quickly, and you give a new life to the patient. You have to work over the carotid artery because the sixth nerve is displaced lateral to the carotid artery. So these tumors come with headache and come with very severe diplopia. And you see this patient is having third nerve and sixth nerve. And this is the smile after about 2 months of surgery. And this person is cured. So if you want to operate on these tumors, there is only one route, transcranial route. And if you talk about any other route and endoscope, I am master of endoscope, I am king of endoscope, you will be king of disaster if you do with that kind of operation. Chordomas. Now I want to give you my opinion on chordomas. Chordomas are tumors which destroy the bone and displace the soft tissue. Carotid artery is displaced anteriorly, cavernous sinus is displaced superiorly, and they are essentially extradural tumors. So when there is extradural tumors, nasal route is a good option. I am not saying nasal route is not a good option, but transcranial is a fantastic option and should not be left for those tumors that extend laterally. So these tumors, if you come from nose, you may not have a good control of the carotid artery. You do not have a control on the sixth nerve, which is so important. So nasal, I will say, if you ask me, what is your approach for chordomas? Whenever possible, transnasal approach is a good option. Endoscopy is a good option, but transcranial is a better option in a number of these cases. You see carotid artery is displaced anteriorly in this chondrosarcoma. I described this in 1995. There is destruction of the clivus and carotid is displaced. So we describe middle fossa subgastrian ganglion approach. Lateral, carotid is displaced anteriorly, carotid is displaced anteriorly, dura is displaced posteriorly. You work in this direction, identify the sixth nerve early in the operation, and you can save it. The problem with transnasal approach is that the sixth nerve is displaced posteriorly on the dome of the tumor, and you may have difficulty in identifying this nerve. So chordoma is a beautiful operation. If you, here you see how much I have done this by a lateral approach. See how the carotid artery is under my control, how the cavernous sinus is under my control, how the clivus is under my control. How on earth you can get such a control by a nasal route? So chordoma's nasal route is a good option in a number of cases, but transcranial route cannot be neglected because it has its own beautiful advantages. We recently described supracerebellar approach to clival chordoma. You see this tumor, and if you come from the nose, it is very long distance. Come lateral, you may be a good option, but what we did was came from supracerebellar. The sixth nerve is displaced medially and on the dome. Identify the sixth nerve early in the operation, and these tumors are like jelly-like tumor, and you can remove these tumors beautifully by supracerebellar surgical route. Even this tumor, of course, can be removed by nasal, can be removed by endoscope, but we had done at that time a supracerebellar route. Advantage is that you can identify, isolate, and protect the sixth nerve early in the operation. So thank you, my dear friends. I hope I have been able to give you my opinion on what I will do in what kind of cases. Basically, my message for young people is that you must learn endoscope. You must learn the art of using the endoscope, because many a time you will get opportunity to use that tool, but don't be a prisoner of that tool and don't start using it for all the indications on the planet. It has specific indications. Never use it for tuberculum celli meningioma. Never use it for olfactory group meningioma. Never use it for trigeminal neurinoma. Frequently use it for chordoma. Always use it for pituitary tumor. Never you can use it for cavernous hemangioma and things like that. So thank you very much, my dear friend. And Samay, over to you.
Thanks a lot, dear Professor, for the excellent presentation. Is there any question from panelists? I think you have made it more clear than enough. That's why we don't see.
I want to hear some questions. I'll be happy if there are some questions.
So my own question about how to make sure that dura is intact during.
Dura will. You must, that is the issue. You must know the power of dura. You must know that the dura is absolute. And if you do not know dura is absolute, it will be a very difficult operation for you. That I have to tell you.
So no tips and tricks to identify it from MRI. It's just a feeling or.
No, you see, every tumor has a different relationship with dura, and that dural relationship I have described, my dear Samay, and that is the thing.
But no show sign that it's.
No, it is sure shot. You sure shot. Like pituitary tumor, the diaphragm will be elevated, work under the dura. Trigeminal neurinoma, work under the interdural. Cavernous hemangioma, always surrounded by dura, work within the dura. All these tumors have defined dural layers. Dura is mother, dura matter. And mother, these tumors respect their mother. And when we are operating as a surgeon, we should respect the mother dura, and work under the dura. And the tumors will respect, and we should respect. That is my argument. Okay, Samay?
Yes, but you said in grade 4 it doesn't respect. So how did you?
Yeah, grade 4. Then the arteries will be encased. Artery of circle of Willis, grade 4, it goes beyond the dura and it encases the artery. So those people who do not respect the mothers are aggressive people. And those people should be treated in an aggressive fashion. And those are dangerous tumors. So we are still working on how to remove those tumors. Basically, grade 4 pituitary tumors are very frequently hormonally active and prolactin level may be high. So you should always, there is a possibility of treating with hormone-related drugs, these kind of tumors. And whether to take biopsy only for those tumors or whether to use aggressive surgery is a controversial subject. Samay.
Okay, is it possible to resect grade 4 totally?
It is possible, and but it is quite a dangerous kind of, you can kill the person also. So when you are going to operate, if you are going to be aggressive, because the perforators are also encased, and you can actually be a very, very dangerous kind of situation.
Okay, thank you, Professor, for excellent presentation and discussion.
Thank you.
I don't
Thank
see
you,
certain fingers and chat box. Thank you.
The king has spoken.
Yeah, John, yeah.
Okay, and now we will shift to next speaker, Professor Theo. Are you ready to start sharing your screen?
Hopefully you can hear me. Can you hear me?
Yes. It's okay. Sorry for making you get up so early. Thank you.
It's my pleasure.
Thank you.
Okay, so if I could just get some feedback and make sure that everyone can see the screen.
Yes, perfect.
Okay, well, hello, John. Hello, everyone else. Good morning, good evening, good night, and welcome. So I have half an hour, excuse me, to discuss the keyhole craniotomy approach.
You have all the time, Professor Theo. Take your time.
Okay, thank you very much.
Okay.
Okay, so the concept is that this is an anterolateral subfrontal approach to the skull base and intraaxial space. There are many indications for this operation: skull base lesions, orbital tumors, hole tumors, supracellular pathology, aneurysms, and even contralateral aneurysms. Basically, the contraindications are any lesion that extends beyond the anatomical limits, and some people are very concerned about the extreme cosmetic concerns of an incision on the face. So what are the limits? In the axial plane, it's, like I said, a anterolateral approach, and therefore it serves the entire floor of the orbital anterior cranial fossa, orbital roof, the ipsilateral clinoid, the contralateral clinoid, the tuberculum planum. Notice that I don't include this area here, the olfactory groove, or the cribriform plate, and it doesn't go beyond the sellar and parasellar regions. In the coronal plane, the reason this is not included is because, remember, it's an anterolateral approach, so it's very difficult to look over we'll call this the hill or the mountain of the orbital roof into the valley between these two hills or two mountains. And therefore the orbital, the cribriform plate or the olfactory groove area is sometimes very difficult to access through this anterolateral approach. If we go further back into the middle cranial fossa, you can reach into the middle cranial fossa, but you certainly can't reach the floor of the middle cranial fossa. So the anatomical limitations in the coronal plane are about the midpoint of the cavernous sinus, and any lesion that extends down to the floor of the middle cranial fossa is unlikely to be accessible by the subfrontal eyebrow approach. The sagittal plane, we can reach back as long as your instruments are long enough, but of course there are lesions that hide behind the dorsum sella, and so the anatomical limits in the sagittal plane is about the upper third of the clivus. Anything below that, it's very difficult to reach over the dorsum into the posterior fossa. Let me give you some examples of the versatility of this approach. Okay, so it's not just lesions of the skull base, it's also lesions within the axial space. This is an anaplastic oligodendroglioma in the frontal pole. Someone had tried to take this tumor out through a cranial approach, through a standard subfrontal approach, and only really got a biopsy. Remember to look for the long axis, that whole concept of the long axis, and you'll see that this approach here that the previous surgeon used couldn't get access, but this eyebrow approach gave us great access to this tumor, and the entire tumor could be removed all the way back to the caudate head and the basal ganglia. Why is it so good? Because again, it's the long axis. You can see the long axis here serves this tumor very, very well and allows you to reach back, as opposed to a standard frontal approach, which did not address the long axis of this tumor. In those days, I used to make the incision above the eyebrow, thinking that maybe the scar would stop the hair growing back and it would have a bad cosmetic effect. You don't have to do that. This supraciliary approach is no longer used. You can do now a transciliary approach through the eyebrow itself, so that you don't, and you won't get a permanent scar in the eyebrow. Here's an olfactory groove meningioma. I fully agree with Atul that many of these tumors should be and can be approached through a transcranial approach because of the reflection of the dura. These are intracranial lesions. And again, you would not do this endonasal anyway because there's too much lateral extension. You can see that it extends across the mid-pupillary point into the lateral part of the orbital roof, and you'd be foolish to try and do this through a endonasal approach anyway. But the point is this, that you can reach into the middle cranial fossa, and if you've got a flat valley, in other words, if the valley is not too deep between the two mountains of the orbital roofs, then of course you can do this anterolateral approach into here as well. So here's, and in the sagittal plane, again, remember I said you can look into the pituitary fossa, you can even look into the posterior fossa as long as it doesn't go too far beyond the upper third of the clivus. And here's the post-op pictures showing a complete resection in all three planes. And again, all done through an eyebrow approach with very minimal secondary damage or collateral damage. Here's some examples of the limitations of the coronal plane. Remember what Atul was saying, that these tuberculum cell meningiomas are best approached through a transcranial approach. I agree 100%. But remember, these olfactory groove meningiomas, sure, you can do them through an transcranial approach, but the anterolateral frontal approach, unfortunately, doesn't give you good access to the cribriform plate or the floor of the olfactory groove. And here's an example of me learning that lesson the hard way. And what I mean by that is that this is a time when I was really sort of stretching the indications of the eyebrow approach. And you can see that the valley between the two hills is actually quite a deep valley. And I tried to get into the valley using an endoscope. So the endoscope will give you really good visualization of the valley, but it doesn't give you good surgical access to the valley. And you can see that I've left some little threads of tumor here, and 2 years post-op, you can see recurrence of the tumor. I think that if I had done this through a different approach, I would have got a much more radical resection and wouldn't have had to do a second operation. Let's also look at the middle cranial fossa. Remember that the morphology of the skull in an adult is different to the morphology of the skull in a child. The adult, the skull base is more flattened, and you can see here that the angle between the anterior cranial fossa, middle cranial fossa, sphenoid wing is a lot more blunt or less obtuse than the child. The child has a very acute angle here. That's why children get retroalar herniation syndromes, and that's why adults don't, because of this flattening of the skull base. What that means is if you're coming from a subfrontal approach and there's tumor involving the middle cranial fossa, then you're more likely to be able to access that tumor through a subfrontal approach in an adult, but to operate at this tight angle is much more difficult in a child. Here's a great example of a tumor extending into the middle cranial fossa that we did through an eyebrow approach. And again, why? Because the anatomical limitations were such that the tumor did not reach the floor, about halfway down the cavernous sinus wall. So you can access this very nicely through this approach. I don't think we've got time to watch all the videos, so this is just a right eyebrow approach. You can see here, this is the floor, the anterior cranial fossa, falciform ligament, optic nerve, anterior clinoid, splitting the fissure now. And again, there's no reason why you can't split the fissure with an eyebrow approach, just like you do with a pterional approach. So we're going to split the fissure. We're going to start working on the tumor. And you'll see here, here's the anterior clinoid, here's the lateral wall of the cavernous sinus. We're taking the tumor off the lateral wall of the cavernous sinus. We're reaching all the way back, and there's the clean dura. So we've got anterior border defined, posterior border defined, medial border defined, but we haven't got the inferior border defined. So this is where the endoscopic assisted surgery becomes very valuable. Again, there's a clean dura posteriorly. There's a clean dura anteriorly. This is the medial component. We haven't reached the lateral component. And that's where we use an endoscope now to make sure that we can really reach out and get all this tumor out. Okay, so optic nerve, anterior clinoid, falciform ligament, carotid artery, medial extent of the tumor, lateral wall of cavernous sinus, anterior extent of the tumor, posterior extent of the tumor, and inferiorly, we're now looking at this is a 30-degree endoscope looking into the middle cranial fossa. Here are these veins that we want to try and preserve. This is a small little vein that we can sacrifice. We didn't see this with the microscope, but you can clearly see it with the endoscope, and you can clearly see that we managed to reach the lateral extent. This is a bit of on-plug and injoma that we can coagulate now. But essentially, we reached the lateral inferior extent of this tumor through an anterolateral eyebrow approach, using the endoscope to confirm that we've got a complete resection. And now we're going to do a Simpson grade 2 resection and burning this on-plug component into the middle cranial fossa. We wouldn't have seen this if we hadn't used the endoscope. So again, endoscopic assisted surgery with the eyebrow approach gives you much more beautiful and clear access to the limits of this lesion. This is a post-surgical MRI scan showing that here's the inferior limit, and we managed to achieve a complete resection of that because we used the subfrontal approach plus endoscope to ensure that we got to this very, very infralateral extent. Here's the sagittal view. Again, you can see how flat this morphology is, so that a subfrontal approach does give you reasonable access down here, and we get a complete resection. Here's where we should not have used an eyebrow approach. So I tried to use an eyebrow approach, pushing the limitations here. And you can see this is the tumor extending into the floor of the middle cranial fossa. Look, residual tumor. So you can't reach down there. Your instruments just aren't long enough, and your line of sight isn't good enough. Okay, let's talk about the limitations in the sagittal plane. The concept here is that the subfrontal approach gives you beautiful access to the planum, tuberculum, and even the sort of diaphragma area here. But once the tumor reaches into the pituitary fossa or reaches behind the dorsum sella, that's when you really need angled visualization and angled instruments to reach into these different fossae. So there's the concept in the cartoon: subfrontal approach, endoscopic assisted surgery, looking over the tuberculum, looking over the dorsum to get a complete surgical resection. Here's a beautiful example of a high-riding tuberculum. So we have to look under the frontal lobe and then into the pituitary fossa to make sure we get a complete resection. And there's the post-op scan showing a complete resection, all done through an eyebrow approach. Again, we make the incision in the upper border of the eyebrow. Here's one where you wouldn't do it through an endonasal approach, because you can see, according to the Gould classification, this is the Gould classification showing that there is intimate involvement of the arteries of the circle of Willis, and you'd be foolish to try and do this through an endonasal approach, because you get much better dissection and visualization of this very delicate and I would say dangerous part of the lesion. So eyebrow, complete resection, preservation of the circle of Willis, and again, reaching back behind the dorsum using the endoscope, because the tumor does not extend beyond the upper third. Complete excision. And again, a very good cosmetic result. Very thin eyebrow, but we made the incision right in the eyebrow, and you can't even see that. Here's another lesion extending beyond the dorsum, but still within the confines of the upper third of the clavus, and therefore this can be reached with an eyebrow approach using endoscopic guidance. That looks like some residual tumor there, but that sort of dissolved. At 3 months, it just disappeared. Complete third nerve paresis after surgery, but good recovery. And here's me again pushing the limits to see if I can get down to the middle third of the clavus, and the answer is no, you can't. You can, of course, if you destroy the cavernous sinus. So this is a lady who has permanent ptosis of the eye. So she's got blindness as well as ptosis. So we destroyed her cavernous sinus. We did a subfrontal eyebrow approach, but we went a transcavernous as well. Went straight through the cavernous sinus because she already had a blind, closed eye. And again, that's why we managed to reach down to the middle third of the clivus, because we did that. And there's the post-op picture showing a complete resection, all done through a small anterolateral eyebrow approach. Here's the technique for those young neurosurgeons watching who haven't used this before. It is very, very important to stick to some pearls and precautions when it comes to the surgical technique, because this incision is very, very visual, very obvious. So if you don't do a good opening and closing, then this patient's going to be walking around showing off your terrible wound to everyone. If, of course, you do it well, then you won't even be able to see it, and it'll be a great advertising card for you. Now, that's very important, because remember, most of our operations are hidden by hair. We really don't have to have too much cosmetic concern, but any operation on the face, you have to be really very careful about your technique. And if you get it right, you'll get these great results, but you can't even tell which side this lady's had her operation on, because despite a very thin eyebrow, the incision is hidden well. Here's a young, attractive girl. Again, the incision is within the upper border of the eyebrow, and you can barely see it. And in all these pictures here, you can barely see the incision. Sometimes you do get, after a few years, some wasting away of the bone or demineralization of the bone, and you do get sometimes this sort of here, a sort of indentation. So I warn patients about that, but I also tell them that we can fill it in for them with some hydroxyapatite if we have to. We have had two terrible complications from the eyebrow approach before I realized what was happening. We bought the new Zeiss microscope, and if you have the light setting on 100%, it will burn the sensitive skin of the face. So this is the first case we did after I bought the microscope, and I didn't realize that you can't have it on 100%. So remember, set the upper limit of your light source on 75% and you won't burn the skin. This is another complication of me trying to exenterate or cranialize the frontal sinus. I don't do that anymore. I'll show you how I manage that in a minute. But we had mucocele and fistula formation because I didn't clean out the frontal sinus well enough. So what I do now is, with the advice of the late Axel Panetsky, who was a very good friend and colleague, and he said, Charlie, look, I know that we're taught that once you open the frontal sinus, you have to cranialize it, exenterate it, take away all the mucosa, take away the posterior wall. That's what we were taught. But he didn't do that. He said, look, every time I open the frontal sinus, I simply seal it off with a bit of bone wax. And he's never had mucocele. Now that I've done almost 2,000, no, not that many, 1,200 eyebrow approaches, I can tell you now that once I started using Panetsky's approach of sealing off the frontal sinus, not cranializing it, not exenterating it, but just sealing it off with bone wax, I too have never had a mucocele. So here's me opening a large frontal sinus. I push the mucosa down, and then I seal it with bone wax, making sure with the microscope that I've got a good watertight seal of the entire frontal sinus before I open the dura. We've only had one unhappy customer out of 1,200 cases, and it's because of this settling after a few years, and you can see the cranial defect, and she didn't like that. And like I say, I warn patients about that now. It doesn't happen all the time, but it can happen in a small minority of patients. You position the patient like you would a pterional with the malar uppermost, so the frontal lobe falls away from the skull base, slight rotation to the contralateral side, and here's the picture, slight rotation. I do a temporary tarsorrhaphy so that nothing gets into the cornea. I mark out the incision in the upper border, staying within the hair. Here's the supraorbital nerve that we try and preserve. Prepping the skin, again, we can prep the skin well because we've got the eye closed. Here's the craniotomy, here's the supraorbital nerve, here's the incision, upper border or within the hair. You don't have to extend beyond the hair. You've got to make sure that your incision will give you access to the keyhole. So here's the superior temporal line, here's the keyhole. So just make sure that your incision will give you access to the keyhole. Try and preserve that supraorbital nerve by dissecting it out. We then do a subgaleal dissection to do a pericranial graft. You've got to really retract the upper border of this incision, and we do that by wrapping the fish hooks around the handle of the Mayfield so that you really pull up high so that you don't shortchange yourself and make your craniotomy too small. Here's what it should look like. Pericranial flap all the way down to the superior orbital rim, dissection all the way to the keyhole, and good superior retraction with fish hooks so that your craniotomy is not too small. Here's your craniotomy, keyhole, burr hole, high craniotomy, and a low craniotomy all the way down to the superior orbital rim. We then drill off the inner table of the calvarium, not the outer table for obvious reasons, the inner table, and that gives you another, sometimes it gives you another 0.5 to 1 centimeter of skull base approach. Again, if you open the sinus, push the mucosa down, put a bit of Surgical in there to act as a bolster, get a perfect seal with bone wax before you open the dura. When you open the dura, you reflect it inferiorly, and you should have this sort of approach where you're looking straight at the skull base and there's nothing in your way. There's no muscle flap in your way. There's no bone in your way. and the dura is reflected inferiorly so that you get this beautiful subfrontal approach without necessity to retract the frontal lobe. Remember, you can get the frontal lobe to fall away just by correct positioning. Watertight dural closure is very, very important. We hitch the dura because you've drilled a lot of bone away here. Oh, sorry, I didn't mention that, of course, one of the other really important things is to drill off the protuberances of the orbital roof. So you not only drill off the inner table, but all these sort of little bumps on the orbital roof, you drill them off as well. The protuberances of the orbital roof are drilled, the inner table is drilled. Okay, we put some covering over that dural closure. We then make sure the gap in the bone is underneath the eyebrow, not on the forehead. The gap in the bone is under the eyebrow, not on the forehead. A low profile closure, whatever you're going to use, make sure it's low profile. We fill in that gap. So you can fill in that gap with bone replacement if you want to. I just use a bit of Surgicel. Replace the nerve. Get a good pericranial covering approximation, and then get a good skin closure. Obsessive skin closure, I use a running subcuticular. And I put a little bit of dressing underneath the tie over, so the tie over doesn't fall into the wound. And it ends up looking, you don't want this to happen where the tie over falls into the wound. So you put a bit of dressing underneath, non-stick dressing underneath like that. Keep pressure on it while the patient's waking up, because when the patient coughs, you'll get a big CSF collection under the wound if you don't do that. Okay, so here's some examples of extended tumours beyond the margins. And this is a craniopharyngioma extending way up into the brain, touching the ventricle. Again, endoscopic assistance, subfrontal approach. Endoscope looks down into the fossa, turn it around, looks up into the brain, and you can get a complete resection of these extensive tumours using a subfrontal approach. What about aggressive recurrent tumours? There's no reason why these can't be taken out through a similar approach, even with involvement of the MCA, previous radiotherapy, previous operations, a lot of extensive involvement of these arteries, and again, a complete resection after surgery, all done through this eyebrow approach. He'd had a previous terional. You can reach further back. This is a lipoma that we left alone, but it grew. And when it grew, the patient got DI. So again, subfrontal, through the opticocarotid window into the posterior fossa. Here's the pituitary stalk, and here's the tumor, completely removed through an eyebrow approach because of this beautiful trajectory to the interpeduncular fossa. And there's the approach: carotid artery, optic nerve, basilar bifurcation, tumor sitting right here, complete resection. That's the anatomy. There's the pituitary stalk. There's where the tumor was sitting. And you can see that it's a beautiful visualization of the posterior fossa through a subfrontal approach. Here's a teratoma splaying apart the two peduncles. So it's in the interpeduncular cistern behind the basilar tip. And again, just to show you the beautiful approach: optic nerve, carotid artery, opticocarotid window, posterior clinoid, looking into the posterior fossa now. Here's P1. Sorry, P1 here. Here's the basilar bifurcation. Here's tumor separating the two cerebral peduncles. So here's the tumor here. Beautiful visualization of the posterior fossa through a subfrontal approach through the opticocarotid window, because the line of sight is the perfect line of sight for this area. Complete resection. And again, in those days, I used to do the incision above the eyebrow. Don't do that. Make the incision in the eyebrow. You don't get a permanent visible scar. Here's a tumor of the midbrain. You can see it presents to the ventral surface. So we're going to do a subfrontal, opticocarotid window, into peduncular cistern, into the brainstem, through this approach. Again, here's a beautiful view. Look at this, opticocarotid window. You can operate through any of these windows. There's the posterior clinoid, third nerve. We're going to operate through the opticocarotid window to get to this intraaxial midbrain lesion. And we're using the endoscope here to make sure we define the edge of the tumor and the edge of the normal brainstem here. And here's the approach, subfrontal, opticocarotid window, into peduncular cistern, into the brainstem. And this is years later, you can see that there's no footprints. Some people say it's a very small approach, and what if you need multiple instruments? There's no problem with that. This is me drilling off the posterior clinoid. I had to drill off the posterior clinoid. And you can see that you can get a drill in there. We've got two suckers, we've got instruments, we've got a drill. It's no problem at all. So here we go. This is a posterior clinoid being drilled off through an eyebrow approach. And again, a complete resection. What if you get a carotid injury? Again, if you get a carotid injury and you get lots of suckers in there, please don't think that it's you can't get suckers in there and you can't get control. This is me with a recurrent meningioma, previous radiotherapy. Things were very, very nasty. And you can see here the carotid. Here's tumor. Didn't have to do much. All I did was just try and coagulate the tumor off the carotid, and I get a hole in the carotid artery. This is all through an eyebrow. You see you've got plenty of room. So there's no reason why you can't manage a carotid injury even through a small incision and a small craniotomy such as an eyebrow craniotomy. Lost a bit of control here for a bit. Here's the hole in the carotid. And eventually we get control. Oh, it looks like I've only got one sucker in here, but you can easily get two suckers in there if you have to. Eventually got control. So yeah, no, we're almost up to 1,500 cases now, 1,450 eyebrow approaches, mostly for tumors. And here's a really important thing. Number of cases that required a conversion to a larger craniotomy, 0. You do get some complications, temporary frontalis palsy, quite a few patients. Permanent frontalis palsy, only 2 patients. Infection, both these cases had the frontal sinus opened, and both these cases I tried to repair the sinus using the cranialization technique, not the sealing technique with bone wax. So here's some pearls and precautions. Go through the eyebrow, not above it. Don't extend the incision below the hair. You don't really need to. Try and save the supraorbital nerve. Make sure you drill off all the protuberances of the orbital roof. You've got to get a good jaw closure or you'll get a bad cosmetic outcome. The endoscope is incredibly valuable looking up and looking down. And remember, at the end of the day, minimally invasive but maximally effective. The supraorbital approach is safe, it's effective, it's minimally invasive, it's a good means of removing tumours of the entire cellar region as well as intraaxial lesions. The major limitations are, of course, the anatomical limitations. It's extremely effective for that line of sight view to the middle, to the interpeduncular cistern and the brainstem. And it's all in the book, Principles and Practice of Keyhole Brain Surgery. Thank you very much.
Thanks a lot, Debo, for this excellent presentation. Is there any question from panelists? Okay, there are two questions in chat box asking about transorbital surgery.
Look, I don't have any experience with the transorbital approach. I think it's just another tool or another weapon in our armamentarium. I really like the transorbital approach to lesions of the anterior pole of the middle cranial fossa, meningiomas that are stuck to the wall of the cavernous sinus, or especially on the dominant side where you don't want to retract the temporal lobe. I think the transorbital approach is very appropriate, but I don't have much experience. I don't have much experience because basically I can reach all those areas using the endoscope. I think you either become very familiar with the endoscope and practice endoscopic assisted surgery with angled instrumentation, or you can, develop more trajectories. I like having, some really workhorse type approaches in my armamentarium. Eyebrow for anything above the midpoint of the lateral wall of the cavernous sinus, and a subtemporal or temporal approach for anything below that. I'm not saying that the transorbital approaches aren't good. I'm not familiar with them, and there's been very little need for me to be familiar with them.
Okay, next question about lumbar drain. Do you use it?
Yeah, look, if you feel like you can get good access to the cisterns and CSF early on in the piece, then no, you don't need lumbar drainage. If you think that it's a large tumor, it's going to block your visualization of any of the CSF pathways, any CSF areas, and you think that you're not going to be able to get to those areas until the tumor is removed, then absolutely lumbar drain is useful. Again, that's very, very uncommon. The number of times I've needed a lumbar drain or an eyebrow approach, I can count on one hand. So in most cases, you do get access to some CSF and you don't need a lumbar drain.
Another question about pathology in Meckel's cave. Do you suggest eyebrow or transorbital or retrosigmoid with endoscopic assisted approach?
So like Atul said, if the majority of the tumor is in the posterior fossa, I use a retrosigmoid approach with the endoscope looking into Meckel's cave, looking forward into Meckel's cave. If it's a tumor that's mostly bulging into the skull base or sphenoid sinus, I use an endonasal approach, either transphenoidal or direct through the pterygopalatine fossa. So I guess this is a good time to say a very important philosophical point, and that is if you're going to start being a skull-based surgeon, it is important to have the full armamentarium under your belt. It's all well and good to have, your favorite approach, but for your patient's best interests, you want to be a comprehensive, well-rounded surgeon that can do all the different approaches, because the endonasal approach is an excellent approach for some tumors that displace the neurovascular bundle laterally, superiorly, or posteriorly. Of course, if the tumor displaces the neurovascular bundle medially, inferiorly, or anteriorly, then an endonasal approach is ridiculous because you're operating through these tiny windows. But some lesions, of course, displace the carotid artery laterally, so transphenoidal approach is beautiful. Posteriorly, transphenoidal approach is beautiful, or superiorly. So you do need to have the full armamentarium under your belt so you're comfortable with all the different approaches.
Next question about large pneumatized frontal sinus.
Yep, I used to say so. If you listen to me talking about this 20 years ago, I used to say one of the relative contraindications for an eyebrow approach is a big frontal sinus. Absolutely not now. You just have to take my word for it. If you can get good sealing of the frontal sinus with bone wax, then it doesn't matter how big it is, it's not a contraindication to the eyebrow approach. So you just have to take my word for it with experience and challenging dogma. So what I did is I had to challenge all the things that were taught to me by my forefathers. You know, as soon as you open the frontal sinus, you've got to cranialize it. You've got to take away the posterior wall. You've got to strip off the mucosa. And we were taught that. And many people still teach it today. But I can tell you now, having done, almost 1,500 cases with opening the sinus in many of those cases, I should write it up, but, we have never had a fistula or mucocele formation if you get a good seal of the frontal sinus. So the answer is no, it is not a contraindication. No matter how big that frontal sinus is, disregard it.
Okay, Professor Goel is congratulating you about your large series. Next
What's that?
question. Professor Atul Goel, congratulating you for your large series.
Yeah, well, it's large in my hands. He's probably done twice as many. But no, I started doing the eyebrow approach when I was a very young neurosurgeon back in Arkansas. Professor Al-Mefti didn't like me using it because he'd had some very bad cosmetic outcomes and said, look, you should not use the eyebrow approach. And I agree with him. If you don't close your wound well, you get a terrible cosmetic result. So you've got to make sure you follow those rules. You've got to get a good closure. Don't use dyed vicryls, use undyed vicryls. Don't destroy the skin. Don't squeeze it with your forceps or you'll get scarring. You've got to be very gentle. You've got to do a plastic surgical type closure of the wound and you won't get those bad cosmetic outcomes. So yeah, I've been doing it for 40 years now, the approach, and mostly for tumors because that's my practice. But, Panetsky himself wrote up two series of contralateral aneurysms through an eyebrow approach. So, with his skill and his experience, he could do aneurysms through this approach as well.
There is another question of Dr. Gian Jubot. Please start asking your question.
Hello.
Yes,
hello.
Go ahead.
I just want to ask, I don't know what your experience is with regards to trauma using the eyebrow approach, whether you've ever used it for trauma. And
yes.
Okay. And then the second is, with regards, I still have concerns with regards to pituitary tumors, sometimes with intraventricular approach, significant components. Do you consider this as an option?
No, you naughty boy. You didn't listen to Atul Gul.
Yes, I've listened to him with regards to being able to remove it all, even though at this point I was out, but he believes you can remove everything. But I've had experience that cases you go transsphenoidal and you're still not able to remove everything. And you still have...
Look, it's good that you said that because we've all had those cases where we think we've removed everything. We do a post-op MRI scan and you go, oh my God, I've left half the tumor in. And so, look, I agree with you that sometimes you get this unpleasant surprise that you can't get a complete resection. But as a general principle, I 100% agree with Atul that pituitary tumors push up the dura, they push up the diaphragm, and they should be approached through a transnasal approach, by far the majority. Now, you're right. Sometimes these tumors herniate through the diaphragma, and you get this portion that is, intradural, what he calls the stage 4 ones. But they're rare. They're rare. By far, the majority of pituitary tumors, even if they extend superiorly up to the ventricle, can still be and should be removed through an endonasal approach. The exception to that, of course, is where they herniate through the dura. They are purely intracranial, and I agree then that they're very, very difficult. Okay, let's talk about what was the first part of the question? The first part of the question was, that's right, yeah. So other tumors through the eyebrow, if they extend up superiorly, yes, you can. Some people take off the orbital rim through the eyebrow. So the eyebrow approach, you take off the orbital rim, and that gives you a very inferior look up into the ventricle. So that's one way of approaching it. If you've got trauma that's involved, so the trauma I've done, the patients who have had frontal sinus blowout fractures, where they have a disrupted posterior wall of the frontal sinus. And yeah, you get very good access through the eyebrow. You can cranialize, you can take away the posterior wall of the frontal sinus, you can take away the mucosa, and you can treat those patients. Of course, if it's a bad head injury with a lot of diffuse axonal injury, there's a lot of swelling, then you're not going to be able to get to the skull base with a big swollen brain. It's going to be very, very difficult.
Okay, thank you.
Thank you, Professor Theo. Is there any tip, any tips and tip to avoid frontalis paralysis?
Yeah, so that's a very good question, because you saw that I had quite a significant number of frontalis palsies. No, short answer is no. Unfortunately, once you start retracting the tissue there, you are going to get retraction paresis of the frontalis branch of the frontal nerve. If you don't go beyond the hair-bearing area, it is very, very unlikely that you're going to cut that nerve. And that's why we've only had 2 permanent frontalis palsies in that series. So please just warn your patients that they will have temporary frontalis palsy. You can't help it because you do have to use quite a bit of traction on the wound to get good exposure of the bony surface. But if you maintain your incision within the hair-bearing area and you don't extend it beyond, then it's unlikely you're going to get a permanent frontalis palsy.
Okay, thank you, dear Professor Theo, and we appreciate all your hard effort to join us in this early morning. Thank you.
It's my pleasure. My pleasure.
Thank you. And now we will finish our 7th session of neurosurgical approaches of EWNC and Neurosurgical TV. And we will meet again in 8th session soon. Thank you all. There is one more lecture for Professor Arturo Ayola. Unfortunately, he can't join us because of some emergency. So we will upload it on Neurosurgical TV YouTube channel. Thank you all.
Yeah, thank you, Sam, and we'll put that video on the chat for people to copy. Okay, thank you, Sam. Great job.
Okay, thank you, John. It was a great session. Thank you all.
Okay, that's a wrap, Sam. That was great. A lot of interaction. Are you there, Sam? Okay, anybody here in the panel want to network? Does anybody want to meet anybody else? Sam, are you still there? Your screen is frozen, looks like. Oh, well, good thing it didn't freeze during the broadcast. Yeah, Charlie and Atul were cooking. Gyang Bot, thanks for your feedback. Where are you from, Gyang?
I'm from Nigeria.
Oh, welcome, welcome.
Oh.
Yeah, we're trying to get something going there in Nigeria, like a grand rounds or something. Okay. If anyone is interested, or if you know of anyone that's very academic, likes to have conferences, etc., let me know, okay?
Okay, sir.
Very good. Stephanie, you there? Or Takashi?
Hi, doctor. Good afternoon. Yeah.
Oh, come on, Stephanie. Get out here and meet some people.
Yeah, I will. I'm having problems with my connections. It's raining right now, so I think our bandwidth is low. But yes. I love to meet everyone, and I really enjoyed every presentation.
Yeah, Atul Goel and Charlie were awesome, right?
Yeah,
Man, oh man.
their work is really amazing. Good afternoon, Dr. Takashi. Sorry.
Yeah, good afternoon.
Hey,
Good
Takashi,
morning.
how you doing?
Yeah, I'm fine. Today, it's now 4 a.m. So I'm in Sapporo, Hokkaido now, and now I'm in Sapporo. So thank you for the lecture. And I'm very interested in attending the India. So I will let Dr. Goel to know about the meeting, future meeting. So I emailed John, and
Oh, you're going to
I
go
want
to the meeting? You're going to go to the meeting?
yeah, I'm very interested in the meeting in January in Jaipur. So I
okay,
would like
great.
to ask Dr. Goel. Yeah, so a
Yeah,
very
he'll
informative
be
lecture. Thank
glad
you.
to help you. Is he? I guess he's going to speak there, right?
Okay, yeah. So if possible, so I prepare the paper, or I'm a member of the English-Japanese translation team in neurosurgery. So
Oh, good.
I'll be a president of this meeting next July. So I will let them know, many people, many doctors around the world know English-Japanese translation system neurosurgery.
That would be great. That would be great. We'll speak more about that.
Yeah.
Okay,
Thank
very
you.
good.
Yeah, thank you.
You've met, and Stephanie, you've met Takashi, right?
Yeah, I know.
Okay. I think you know her,
Yeah,
right?
good afternoon, Dr. Takashi.
Yeah, good
Glad to hear
afternoon.
from you once again. I was
Yeah, good
listening about this neurosurgery translation team. It looks awesome.
Yeah, okay. So I will attend this meeting. So now it's 4 a.m., but I'm very interested to attend. Thank you.
You know, Stephanie, the dream of Takashi and me is to travel the world and to do conferences all over
Yes,
the place, right, Takashi?
Yeah, and my future plan is to visit all over the world in neurosurgery as a neurosurgical trip.
Yeah.
That would be great. That would be great.
Yeah, that would be great. Maybe we can get more countries involved in the countries we're missing.
Yeah.
Sure. Okay.
Thank you.
Very
Okay.
good. Anybody else out there want to meet us or meet anyone else on the panel? Bayam Batson from Mongolia. Are you there? Is your audio working? Your video working? Bayam Batson? There's a neurosurgeon from Mongolia, Stephanie.
Yeah, I think it was Dr. We were waiting to hear from him for a lecture, I think.
Oh, okay. You mean Dr. Ayala from Mexico?
Oh, no, you told him on the chat that you were waiting to hear from him.
Oh, okay. From Takashi.
Yeah, from the doctor from Mongolia. I saw.
Oh,
the
yeah,
chat.
yeah. I'm waiting to hear. I guess those aren't private chats, but that's fine. Yeah, she mentioned wanting to do Mongolia Grand Rounds.
Oh, yeah.
Because there's only like 50 neurosurgeons in Mongolia. However, they need teaching. So
yeah.
So maybe we'll get her to kind of organize it. She's expressed interest in it. And such a big country, this would be very good. Are you there, Bayam Batson? I see your microphone's on. I don't know if you're, yeah, maybe I have to promote you to be able to, yeah, you can't speak without.
Oh, yeah, Dr.
Oh, yeah, she's in now. Okay.
Okay.
Maybe we can talk to her. Okay, are you in there, Bayam Batson?
Oh,
Can you
yeah.
hear me? Can you hear me okay? Yeah, she's in there. Maybe she's having some bandwidth issues.
Also, Dr. Ahmad has his micro on. Dr. Ahmad Fawad.
Yes, hello. Salam
Oh,
alaikum.
there he is from Afghanistan. How are you doing?
Yes.
Good afternoon, doctor.
Fine, thank you. Very nice and great webinar. excellent presentation. Thank you.
Yeah, today was very good. It's very special. It was very good. Very good.
Thank you,
Had
Professor John Barrett.
you had some really good lectures.
Yeah, the lectures were really amazing.
Yeah. If Dr. Tio's doing tomorrow, we're doing China. He's doing China, the Neurosurgical Journal at 7 o'clock Eastern time. That would be early for you guys. It would probably be 6 a.m. Central time, which I think is Bolivia. What time? And Bolivia is 1 hour before, right?
Well, right now,
1 o'clock now.
3 p.m. right now. 3 p.m. in
Oh,
the
3
afternoon.
p.m. Boy, the times are getting strange. Now it's ahead rather than behind. Usually it's behind time.
Oh, okay.
But
So
keep an
I
eye
think
on
maybe
that.
the webinar tomorrow is going to be at 8 o'clock Bolivia time, I think, maybe.
Yeah, well, it's going to be 7 o'clock. Yeah, I guess so, because 7 o'clock Miami time, Eastern time. So yeah, that would be 8 o'clock Bolivia time.
Okay.
So
Great.
very good.
Dr. Bayam Batsen is here, and the panelist, Dr. Bayam Batsen.
Are you there, Bayam Batson? Can you hear me okay? I think she's in there. She was.
Yeah, she's on the panelists, but
she was brought in. Yeah, maybe, I don't know, maybe there's a problem. Sometimes people call or we're in the hospital doing rounds.
Yeah.
So not everyone is free. So,
yeah.
Okay, very good. Okay.
Thank you.
Thanks, everybody. Thanks, Stephanie.
Hope
Thanks.
to be here tomorrow. Thank you, Doctor.
Okay, great. Okay, thanks, Nicholas. And thank you. Okay, thank you, Ahmad from Afghanistan.